Okay, good morning, everyone. I want to call this meeting to order and ask that we, as a reminder, that everyone please turn off your cell phones and make sure they're off the table. Please make sure your BlackBerries are also off the table so we can avoid any feedback. I'd like to ask that all speakers complete a presenter slip. Some of you already have, but I want to remind you that I'd like them handed to Ms. Thompson. Ms. Thompson, if you'd raise your hand in the back, make sure you hand your speaker slip to her, and she will bring them forward so we can maintain some kind of semblance of order here, please. And remember, please, 3 minutes on the clock, as well as remember that we will not be having a discussion up here, that it is your opportunity as a member of the public to give us whatever input you'd like, and that is it. For the record, we are reconvening the board meeting from yesterday, and thus I would ask Ms. Thompson to please call the roll.
Good morning. Dr. Karyan.
Here.
Ms. Chang. Here. Dr. Chin. Dr. Diego.
Here.
Dr. DeRusso.
Here.
Dr. Israelian.
Here.
Dr. Levine. Dr. Lowe. Dr. Moran.
Here.
Dr. Solomonson.
Here.
Ms. Shipsky. Mr. Zeranian. And Ms. Yaroslavsky.
Here.
We have a quorum.
Thank you very much. I do. I have from Mr. Formansky, Dr. Formansky, a speaker slip I have for you on something that's not on the agenda, sir.
That's correct. I have a handout. I don't know if you'd like me to give it to you
You
at
can
this
give it to
point.
Ms. Thompson.
To which?
Ms. Thompson, give it to staff. And the reason for that, I want the public to understand, is that we don't want to have to take a situation where we would get something that might put us in an awkward position, either of conflict of interest or...
I have enough for everybody if Ms. Thompson would like to take them.
Thank you.
That is,
Okay.
board members at least. I'm here mainly to talk about two pieces of terminology related to yesterday's presentation. And that has to do with when somebody goes to PACE, particularly postdocs, people who have training in a specific area, often subspecialty training or specialty training, PACE is unable to validly test them. They call it assessment. Those are those written tests. It turns out that there's a term of art called content validation. If you want to test, I'll say, a neuroradiologist in PET scanning, you have to test him with the scans. You have to have a normalized curve of population. You have to have a lot of things which PACE doesn't have. That means when a highly trained person is referred to PACE, PACE is without the proper tools to test them. The same would apply to a doctor who does ERCP. You have on your board a craniofacial reconstructive surgeon. The same would apply to that person if they were referred to PACE. There is no assessment material. They're shooting in the dark. They very often what they do is use the wrong test. I gave you the result of a lady who did laser surgery, but they had no laser surgery test nor dermatopathology or any other test. They gave her a test in obstetrics. Apparently she failed. There was a scathing report and she lost her license. I'm here to, my 3 minutes isn't up, by the way. One term of art is content validation. I want to know if you've content validated any test for neuroradiology, PET scanning. I'm interested in neuroradiology, but I put in a couple of other ones. For instance, transplantation. You have a transplant expert on your board. I'd like to know if you've validated it that way. There's a second form of validation, it's population validation. If, you might say, well, why don't we just take a chimpanzee and put him in a closet and he'll come up with some kind of test and you'll call it the test for neuroradiologists. The reason you can't do that is that test you would have to find 500 radiologists or 1,000 neuroradiologists, give them the test and then normalize it, with the normal curve, set standard deviations and come up with some sort of cutoff for what is good or bad or high scoring. And you still wouldn't know who was incompetent unless you know which proportion of those 1,000 neuroradiologists were incompetent. That has to do with population verification. PACE doesn't do that. Apparently, the medical board doesn't do it either. There's a request that's been filed with the Sacramento board office and also here asking, did you ever validate any of your tests for neuroradiology, radiology, PET scanning? And I put in a couple of the other ones, which I'm not a cardiac surgeon, but you have one on your board. You have a craniofacial surgeon. I asked, have you ever validated it for any of the subspecialties? including the poor dermatologist lady who did laser surgery. Apparently she lost her license because you did not have the right test to test her. You referred her to PACE as a sort of subcontractor, quick and dirty tester. And you should see the report they wrote. 17 pages. I saw the report. You probably haven't seen it because it's secret. Done on the so-called secret, the secret template. I asked in your last meeting, it's in the minutes, for the Enforcement Committee, what in the world is the secret template? I really haven't gotten that answer.
Dr. Fermansky,
I
you need to
realize
wrap
you-
it up now, please.
Yeah, I'll terminate it at this point. Thank you.
I have no other public comment slips for items not on the agenda, so we're going to move on to item number 10 from the agenda. The Physician Assistant Committee, which has not, I'm going to make this report in Dr. Lowe's absence. The Physician Assistants Committee has not met since the last meeting of the Medical Board in July. It was scheduled to meet earlier this week, but due to scheduling conflicts, a quorum could not be obtained. Instead, the committee will meet on November 18th in Sacramento, California. Are there any comments or questions from the members of the board on this? Are there any questions or comments from any members of the public? So seeing none, we're going to move on to item number 11 and an update from the Federation of State Medical Boards. Ms. Chang?
Hi. Can you hear me? Did I do it? It's on.
Yes, it was just the motorcycle going by.
Oh, okay. Well, I have been busy since last board meeting for the Federation. Since I got elected to the foundation of the Federation, we have to start working on different projects. I was in Memphis, I was in Washington, D.C., I was in Santa Fe, I went to Seattle for a project, and I was in Chicago. So needless to say, last 3 months has been very busy. I want to tell you what some of the things that has been happening over in Federation. They finished their $4 million investment in improvement of the FCVS program, and right now in the testing stage, and hopefully they will come up with a great product. They have a new telemedicine committee formed that is pretty much based on the new administration's goal to establish maybe nationwide, good telemedicine model. And one of the issue is the MOL, which is called maintenance of license, and which is going to be a very important issue, and it's for the people who has been in business for a long time, and how to maintain the competitiveness, or how good they are. It's an issue has been going on, and the implementation group will come up. It would take me a little longer to give you the full report since we didn't do one last time. Okay. And the third one is actually the called re-entry issue. The re-entry is for the doctor who are out of practice who has wanted to come back in. And we formed a committee in doing just that. Then we have a new it's the Physician Impairment Committee, and Dr. Bolton, who has been at one point a licensing chairperson, is on that committee and chairing that committee. And so is Dr. Fantozzi. Dr. Fantozzi was our board president. He is on that committee also. And then for our own, Janet, and is going to be, she's agreed to participate in the writing for the United States Medical Licensing Examination, which is happened to be in April, is a very big thing. So thank you, Janet, for doing that. This is the portion on the Federation itself. the portion on the foundation. Now, yesterday I was talking to some people about the foundation project, and people say, I never heard that the Federation has a foundation. It does. It's a small foundation. The Federation only put out $2 million as an endowment and gave the foundation about $500,000 as an operating cost. Since the inception, we had done quite a few projects, but the most recent one which I got involved in is the public member project, which is how to educate public members, and did some surveys, and I think our board has participated to it, and it's going. And number 2 project is the violent project. They call it violent project. Is basically talking about the threats to the board members or to the staff members of the state medical board. That is a very ongoing issue. The head of the Arkansas State Medical Board get bombed by one of the doctors who got into a discipline. And the head of the Texas Medical Board, she got life-threatening notes in person, and
It's not going to happen in California, don't worry.
okay, well, but there is a survey coming out, and I think our board is participating in that to see how widely is this program. And the third one, which is closer to my heart, is actually will be interesting, is an evaluation of all the state medical board. You all know Sidney Wolf put out a report and just ranking and all the boards. And it's not a very complete picture. So the foundation is on its way to come up with some good criteria, and we will need some of yours help to make it happen and to evaluate the whole state board, and then maybe it will be a good product. Well, at least we're hoping so. And we'll have everyone, the administrators, the board members, support into this project. So it's wonderful. So that pretty much concludes the report. I did want to say I am very, very pleased and happy that they actually put me on the foundation. And there's only 2 board members from the Federation is on that foundation, and I am excited. You know, even my volunteer work is taking over my life, but I feel like I'm doing the right thing. Thank you.
Thank you, Ms. Chang. Thank you very much for your report. Moving on to item number 12, the nomination to the Federation of State Medical Boards. Federation of State Medical Boards is seeking nominations on a variety of items and positions, including its board of directors. These include resolutions to the Federation's House of Delegates, nominations for distinguished service, award or clerk leadership awards, nomination for associate members. At this time, I recommend that we not pursue any of these because we have not had any discussions on those subjects. With your concurrence, though, I will entertain a nomination to the FSMB directors.
I would like to nominate Ms. Hetty Cheng to continue.
Do I have a second?
Second.
Is there any public comment on this nomination? Is there any comments from the board members? Seeing none, I'll call the question. All those in favor of this, please say aye.
Aye.
Any opposed? Congratulations, Ms. Chang. We will direct staff to submit that nomination on behalf of the board.
I'd also like to encourage the rest of you, though, to consider getting involved. And if you want to be on the nominating committee or any of the other committees, it's a great way to get more involved.
Thank you for your involvement, too, Dr. Moran.
Thank you.
Yes. Yes. Yeah.
Okay, I'm going to move out of... Do you want me to continue here? Or should we finish those? Okay, we're going to just take a couple of minutes and complete a couple items on the agenda before I mix it up a little bit more. Excuse me, what?
You're setting up her, so go ahead and take the next.
Okay, Mr. Shunke, could you please come forward and present on items number 13, telemedicine pilot project status report?
Good morning, Madam President. And I'll keep it much shorter than I did yesterday. You have before you the report which I presented instead of going through much of that again. I think to summarize, at the July board meeting last time, you had Dr. Nuovo here presenting a summary of the full year's recap of the telemedicine program. I presented a report to you here that just brings you up to date on what's happened since then, the sites which are coming up and so on. And then lastly, on the bottom of page 102, some of the new outreach efforts they're trying to work with and some of the miscellaneous issues for them to follow up with.
Thank you, Mr. Shunke. Is there any questions from any of the members of the board on this? I have no speaker slips, so we'll continue on. Number 14, please.
This is my report on the licensing outreach. As I've said before, been there, done that, continuing to do it. I think it's being very successfully received. Yesterday, we had representatives of the GME office from Kaiser Permanente, Los Angeles, from UCI and Loma Linda here to participate in the meeting, especially the licensing committee. I would like to express my appreciation to President Yaroslavsky and other board members who, as their schedule allows, have been able to participate in some of the licensing outreach efforts in which I've participated around the state. Some first-time visits which have been accomplished since I last spoke to you. I had a brief licensing fair at USC, LAC Teaching Hospital. I'm hoping to extend it a little bit more with their cooperation and have several more hours available. I participated in a licensing fair at Huntington Hospital, Pasadena, Children's Hospital, Los Angeles, and I was very excited when I got off the plane last Friday night at midnight in Sacramento to see Dr. Chin welcome me home. However, he was actually there to pick up his wife, who was on the same flight as me. He was not there to welcome me back.
Role reversal.
And next week, I will, on Tuesday, be participating in an all-day licensing workshop at Loma Linda Medical University, which will be the first time that I've been on their campus for a licensing fair, although I have been participating in new resident orientation there for quite a while. Last night I was trying to go back and sort of estimate during this year. Now Loma Linda will be my last event of this calendar year. I've had direct contact or either presentations as part of a group to about 2,000 of our applicants to the medical board. So I think that there's been a tremendous outreach to the community. In 2 weeks, the medical board will be hosting 2 outreach meetings with the GME staff throughout California. We have sent letters of invitation to 200 GME directors and deans around California from all the teaching hospitals. We'll be hosting a meeting on November 15th in Oakland, and the following day, November 16th, at Kaiser Permanente in Anaheim. And one of the items which was handed out to you is the agenda and the letter of invitation which was sent out. We have also offered similar outreach opportunities to CAPG, California Hospital Association, California Primary Care Association, and CMA to continue our expanded outreach to physician recruiters. And the last thing I'd like to report on is that just last week we sent out about 1,100 letters, again to the 200 GME directors and deans, as well as the 875 to 900 program directors in California, asking them once again to continue a project which we started several years ago, collecting names from them of the people who they identify as needing licensure by July 1 of next year. The letters went out on Friday. By Monday afternoon, we'd already received 13 requests and responses of people of hospitals wanting to participate. Last year, we got about 1,800, 1,900 names on our master matrix to help us identify and the licensing program staff to prioritize their workload so that these residents, these unlicensed folks, could continue in their training programs here in California, or if they're coming from out of state, could begin their training here in California. Are there any questions?
Any questions?
Well, I just want to publicly thank you for your efforts, and as chair of the licensing committee, I think I've been watching those work reports with great interest, and I think your matrix has been huge. Obviously, the staff has been great in processing, but I think that's been huge in getting that backlog down, and obviously it's a access to care thing when the people needing licenses can get on the job in a timely fashion, and I thank you for your efforts.
Thank you.
I also want to thank you for your efforts on behalf of the entire board. Mr. Shunke, I think that under your leadership and with the direction of our executive director, Ms. Whitney, this has really proven to be a major bonus for this medical board as far as our public persona out there in the community of being able to take those licensees and get them licensed in a time-appropriate fashion. And I would urge all of the members here, if and when you have the chance, there are 2 meetings, as you heard, that are listed, one in Northern California, one in Southern California. If you can have the time, if you can make the time to even stop by for half an hour, meet the GME, see what's being done, I think each and every one of us will be equally as impressed as I was when I stopped by UCLA, and I want to thank you for that.
Thank you. I've been with the state 26 years, and it's probably one of the most fun assignments I've had, and I appreciate the board giving me the opportunity to go travel, meet the folks, and put a positive spin on the board as opposed to, a regulatory agency.
I want to thank you, and I want to thank Ms. Whitney as well, because and Dr. Summonson, thank you as well. We're now going to move a little bit out of order again to item number 23, where we have a healthcare reform presentation, and I would like to ask Mr. Herb Schultz to please come forward to the table as I introduce you. Herb Schultz was recently appointed by President Barack Obama to serve as Regional Director at the U.S. Department of Health and Human Services, better known as HHS, Region Number 9. In this role, he serves as HHS Secretary's Sebelius' key representative in this region, ensuring that close contact is maintained between the federal government with the state, local, tribal, and territorial government, and external non-governmental partners on a wide range of health and social services social service issues. My apologies. HHS Secretary Sebelius, in announcing Mr. Schultz's appointment, said, Herb Schultz brings an extensive working-level knowledge of our department's most important issues, as well as a knowledge of the people and institutions in Region Number 9. His experience and talents will be invaluable as our department works to effectively implement the Patient Protection and Affordability Care Act. Previously, Mr. Schultz was Senior Advisor to Governor Arnold Schwarzenegger and served as the Senior Health Policy Advisor to the Governor during the California's 2006 to 2008 state debate on comprehensive health care reform. He was Deputy Director of External Affairs for California Department of Managed Health Care and served as Director of the Advisory Committee on Managed Health Care under the Davis administration. Welcome, Mr. Schultz. Thank you for being here, and you have the floor.
Thank you, Madam Chairwoman.
Oh, in the interest of full disclosure, I do know Mr. Schultz personally as well.
I know most of you, so I appreciate it.
I apologize. I should have said that to start with.
That's okay. I'm not even sure I need the PowerPoint, but it'll take probably a little while to do that. But thank you. You didn't have to read the whole bio, but thank you for doing it. I got a little tired of it.
You might know your biography. We don't. Not all of us.
It's a pleasure to be here, and it's a pleasure to be back here, I should say. Many of you I know and have worked with, and it's a real pleasure. I appreciate the opportunity this morning to spend a couple of minutes, and I promised a colleague that I'm here that I'll take no more than 10, because I would really like to have a discussion with you and to see what is on your mind. I'm pausing a little bit because he's so fast with this. I'm going to let this go up while we do that. So let's see if we can get that up first.
That's yesterday's presentation, if you'd like to see it.
I know we loaded this one. Do we have mine on here? That's not mine. That's from yesterday. That looks like it. Okay. What I wanted to do is really just spend about 10 minutes, talking with you about the Obama administration philosophy, sort of underscoring the implementation of healthcare reform. And by that I really mean the new role in this administration of the regional office of HHS, my role, and I think a very strong potential for us to work very collaboratively from a day-to-day, week-to-week, month-to-month perspective. It's a very different implementation philosophy, and it is not just obviously healthcare reform, but my swath is the entire Department of Health and Human Services. So whether it's social services, human services, healthcare, but I utilize healthcare reform because it should go without saying, but I think it's important to note that the number one priority of the Department of Health and Human Services and in the administration on healthcare is the implementation of the Affordable Care Act. But there are many things I think that physicians and the board and your physician members obviously and as well as the community writ large will see that there are a number of other priorities of the Department of Health and Human Services which sort of span the spectrum, and many of them in which you get involved in. So you could see a number of them, but what I'll use is the example of the healthcare reform because it is opportunities where, in coming to you this morning, it really is to talk about opportunities for collaboration and partnership with the board, and that's where I'll focus my remarks. Obviously, that's the statement that the President made just a little bit over 7 months ago about the implementation of reform. Many of us have fought our entire lives for the implementation of comprehensive health care reform. Whether it's the same vision that everybody has, this is the vision that the Congress and the President and the Secretary came around to and what we're implementing now. So let me just spend a couple minutes sort of talking about this and the opportunities for collaboration. In the past, the role that this role had was a public affairs job. That's not the way that it is in this administration. The regional director, the regional director's office is there from the department level to, from a day-to-day, week-to-week, month-to-month perspective, be able to have an ongoing relationship with you. If you will, it's sort of bringing the federal government to the local and regional level. You may, in the past, and I'm sure in the present, work with the Health Resources Services Administration. You may work with CMS on various issues. You may work with various other licensure agencies within the federal government, within HHS, whatever it happens to be. But this is the first time in the history of HHS, HEW, or anything that came before it that there is this ability to, if you will, sort of work at the department level. So I sit as a presidential appointee on the Secretary's senior team, and what that really means, that's not the important thing. The thing that means is that in our region, whether it's education and outreach, whether it's policy level discussions, and I'll talk about that in a moment, whether it's potential grant opportunities that are for state, local government, or even community-based organizations, provider systems, physicians around health information technology, or whether it is really sort of working with you to publicize some of what physicians in the physician community are doing in health and social services, whether it's healthcare reform. It's a day-to-day, week-to-week relationship. So I use the example this way. If you take the issue of accountable care organizations and the interest that the physician community and other providers and consumers and others have in that, as opposed to waiting until a formal notice of proposed rulemaking comes out and says to you, okay, well, here's how we're going to structure or set up the accountable care organization system. That's the formal opportunity to have input into the Department of Health and Human Services process, and that's important. What we're bringing you is the ability on a day-to-day to work with us on an informal basis, to be able to share with us what you're thinking, what your views are, either collectively or singly, about some of these really important things that are going to impact the physician community, the future physician community in California and throughout this region. In other words, the expectation that my boss, Secretary Sebelius, has is that we are going to work with you to ensure that as we're developing regulations, that we are able to work together, that we're able to gather your views so that we don't have the situation when you come out with a draft regulation saying, well, okay, I'm commenting now and, 50 other medical boards are commenting, or 100,000 other people are sending in comments on the exchanges, which are things that I think you're going to be obviously interested in. And so while we don't run the programs, all of the various administrators, CMS, HRSA, the Administration on Children's and Families, National Institutes of Health, all those folks sit on my regional management council so that the ultimate goal for the local and regional level is one HHS. And so it is a one-stop shop. It is a troublemaking organization. It is a way to have you say, oh my God, we have to look 3,000 miles away to Washington, and where do we have to talk about this particular issue when you now have an office that's structured only political appointee of the departments sitting in the region to do that. So if you can see that collaborating, coordination, troubleshooting, partnering, educating the public, working to implement reforms. So this is the first time in history that not just working with state government, which has been the role in the past, federal, state, local, tribal, and territorial. So I have been out to a number of the physician societies and others across this region, but also the key non-governmental stakeholders. And so if we have to troubleshoot, if we have to bring issues together, the power of convening in my office is a big one. And so I just put this up here to sort of remind us that this law is not just about government programs. It is about the private market as well as it is the public market, but there's significant opportunities that we could talk about in the prevention realm with community transformation grants, with the notion of zero co-pays, deductibles, and co-insurance on preventive health services, on increased reimbursement for providers in Medi-Cal and Medicare, the CHIP program, the Public Health Fund, as I said, $15 billion. And the reason I'm putting these up is to demonstrate that there are a significant way that I think we can interact. And in my last slide, I'll talk for 2 minutes about a potential set of partnerships that maybe that we could do. I think it's important, especially for physicians, to mention the First Lady's Let's Move initiative. It is something that, as the regional director, I take the lead on the part of the campaign for Mrs. Obama and the Secretary on Let's Move Cities and Towns. And we have been throughout this region in all of the states and now in a couple of the territories, and I'll make sure I sort of state how large the region is, signing up local mayors, local towns to the Let's Move initiative. But this is something where I think that obviously not just physicians, but the whole community really does have an interest in eliminating childhood obesity. This is within a generation. You can see the pillars: helping parents make healthy choices, healthy schools, healthy and affordable food, physical activity. And the reason I mention all of these is because much of this law, beyond the strengthening of primary care, ensuring access to specialty care, is about a whole different way of doing things and focusing our system not just on sort of individual preventive health and making sure that the provider capacity and workforce is there, but on community-based prevention. And that's something I've always seen, that the medical board thinks much broader than the individual physician, but thinks about the community and the communities writ large. The workforce issues that I put through on there, worker training, and a significant number of programs, National Health Service Corps and others, where dollars are starting to flow in. And I also would be remiss if I didn't mention that there is now a significant administration-wide initiative between the Attorney General, the Secretary of Health and Human Services, and throughout on tools to prevent fraud. And many of them have already begun to be implemented, and something that obviously we could work with you on. So if we get down to sort of brass tacks, so I can open it up, we had the opportunity to do a pre-call with Linda and with Jennifer, and congratulations, Linda, because Linda and I used to be counterparts when I was at the Department of Managed Health Care, and it's nice to see her in an executive officer position. Some ideas for outreach and sort of partnerships with the medical board. One is obviously what I've talked about, the day-to-day, week-to-week, month-to-month relationship, education and outreach, policy, grant opportunities. But there are other opportunities in terms of the potential. We'd be very open to co-hosting some workshops across the state on key issues of mutual interest. Obviously, it's more than just the implementation of health reform. That's a big one. But the fraud pieces or other pieces around community-based prevention, we think that physicians play a huge role in the transformation of communities. And these community transformation grants that CDC will be coming out with is a key part of the preventive agenda that the President and the Secretary put together. So that's another idea. And another one is we're in various communities throughout the region. And so we do think it's important to highlight the role of the physician. And so I've been able to go to community health centers, I've been able to go to hospitals, I've been able to go to doctors' offices, I've been able to go to different events, but at the same time utilize it as an opportunity to help get public attention on some of the creative programs, some of the creative things that physicians, consumers, businesses, labor, other providers, plans, academics, philanthropic organizations are doing, not just around reform, but that's a very good one to be able to say, here's a way that we can educate individuals, because 2014 is around the corner. 2019 is a 10-year implementation, but in terms of everything that's going on, this department in the past, we understand that it has not always presented itself as one HHS. And so a large part of the role that I've been asked to play in this job is to ensure that we are working with the community at the local and regional level as one HHS, so that you're not sort of struggling and saying, well, we need to sort of talk over here about physicians and community health center environments and teaching health centers, but over here we're talking about durable medical equipment and, you know, da-da-da-da-da-da, or this or that or the other thing. And so our hope is that not just these three, but that maybe we can come up with some opportunities to partner with you, to partner with the other medical boards in our region. I call the region my 4, 3, and 3. It's 4 states, California, Arizona, Nevada, Hawaii. It's 3 territories, Guam, the Commonwealth of the Northern Mariana Islands, and American Samoa, and the 3 island nations through the Compact of Free Association of Micronesia, Palau, and the Marshall Islands. And we have an organization in this region, the only one of the 10 regions of the department that has what's called a Federal Regional Council, which I'm honored to chair. And it's the 19 federal agencies that are anywhere in the West and in the Pacific. And in 2 weeks, we're going to be honored with the 3 governors and the 3 presidents visiting us and meeting with the Federal Regional Council. I mention that because when you talk about healthcare reform, when you talk about any type of health or social services, you know, one of my former bosses used to say, well, healthcare reform is not just about a delivery system, it's about the social determinants of health. And so I have my counterparts in HUD and the Department of Labor and EPA and a number of Social Security Administration and the Defense Department, the Interior Department, and a lot of other agencies, Treasury, if you will, which obviously has a huge role in the implementation of reform. So that's sort of my piece. As always, I'm going to call out my cell phone and my email. I invite people to, you know, take us up on our offer. We have a listserv that now is probably over 2,500 organizations in my first 6 months. Either people can send an email or give us their card. I know some of you are probably already on it, but we try on a weekly basis to send out a few things about what's happening in the department, especially around implementation, but other things. So there are grant opportunities. There are regulations that are coming out all the time, and as you've seen, CMS has done some recently on physician payment and a few other things, or the preventive health measures in reform. So the cell phone is area code 415-265-7049. That's 415-265-7049. And the email is Herb. As everyone knows, I'm not a Herbert, thank God. H-E-R-B, no offense if there's a Herbert in the audience. H-E-R-B, and then it's spelled the East Coast way. You can tell the accent, S-C-H-U-L-T-Z. I have a joke with George and Charlotte Schultz because they say that their way is the right way, and I say, no, well, I won't do that joke either. Anyway, S-C-H-U-L-T-Z at HHS. .gov. So I'm happy to open it up, but this was really hopefully just a very brief stop to say we hope that we can have a, week-to-week, month-to-month, day-to-day relationship with you. And if there's things that you'd like to do maybe with the medical boards in the other states in the region and the other territory, if there's some things we sort of want to do that there's like issues together, we're very, very open to doing that. So, thank you.
Thank you, Mr. Schultz. Do I call you Mr. Schultz, Director Schultz?
Herb.
Herb. Thank you, Herb.
Yeah, Mr. Schultz is 78 and he lives in Cherry Hill, New Jersey.
I
And
wanna
he
thank-
reminds me of that often. I don't call enough.
Your genes are good. Your
Yeah,
genes are good.
yeah.
I want to thank you very much on behalf of the board, first of all, for taking the time and the energy and to not only explain to us, but to bring to the table the opportunity for engagement, involvement, collaborative opportunities that might be available. And each and every one of us have our own constituencies or additional constituencies in addition to the medical board. And we need to look beyond the rooms, the walls in this room, or maybe not so far beyond the walls in this room, for where help is necessary and where the opportunities do lie. So I want to open it up now to members around this horseshoe, if you have any questions or of Mr. Schultz, of her, please. Hetty, I know you're chomping at the bit. Go ahead.
Well, it's the same question I keep on asking, and I think I finally got some person who can do a elaborate, good answer.
I hope, Hetty.
Well, it's a workforce issue. I think with the primary care, there was 15% shortage by the American College of Medical Schools. And then with the new one coming in, it's another probably close to 15% influx of the additional insured. So it's about 30% shortage if we looking at it in some way, okay? I know we put in the administration putting some money into the pay for the primary care, put some money for maybe, or looking to put some money into the medical and for the residency programs. But somehow that doesn't seem to be able to cover the whole 30%. And with increasing of the nurses' responsibility, it put somehow the medical board in a very, in a funny, we need to look at the issue very, very closely. But my question is, what's the future plan to increase the workforce, maybe for physicians?
Right.
So-
I think it's and it's a great question. I think it's very, very significant. I think that when you focus on the Public Health and Prevention Fund within this historic law, it's $15 billion. And so this year has been the start, and I should say 2010, FY 2010 has been the start, because we already have used $500 million, the first year's allotment, to strengthen the primary care system. There's over $168 million that's put into residency programs and some other things, and it just only, if you will, increases from there. So there's a significant amount of physician education, training, loan repayment, growth of the National Health Service Corps, and other things. And then you're right, there's a lot of stuff there for nurse practitioners, physician's assistants, school-based health centers, nurse-managed clinics, and the like. But I think that there is a significant amount of dollars that will continue to flow towards the growth of the physician workforce in any number of ways within that $15 billion slot. And so what I have asked a number of folks is to, I was like, oh yeah, we're in the hospital. What I've asked folks is that because of this day-to-day, week-to-week, month-to-month, I can go through with you and say that in X year we're expecting X dollars, Y, or this is what the plans are. It's helpful to then know in advance, what are the programs that you think should be done. Let me give you an example. There's a couple of universities in the state that are growing medical schools. And one of them in particular has raised a really good point with me, and that is, well, you're giving this money to four-year medical schools, the residency programs. What about those of us that are sort of like, halfway there or almost there? What are you doing to help us get done to be able to get that physician capacity? And so I've had conversations with Mary Wakefield, the head of HRSA, and other folks within the department about that. So you're exactly right. I mean, I've said to folks, before March 23rd, I think my question would have been, my answer would have been, question mark. Now at least I know with the Public Health and Prevention Fund and $15 billion, a huge part of this law is about strengthening the role of primary care physicians. And so I'd love to then sort of talk about what areas you think and what things there.
Thank you.
Herb, as you well know, this board has taken a leadership role in trying to provide some kind of loan repayment program for physicians willing to serve in underserved communities for 3 years. And through the efforts of this board specifically, legislation was carried, and now $25 of every doctor's licensing fee is going into the Health Professions Fund to help fund those costs. Every year we are turning away 20 to 30 doctors who are more than willing to participate in this program, who are more than qualified to participate in this program, and who are not able to participate in this program because of a lack of funds. Now, I know that there's the National Health Service Corps, which is a different program run by OSHPD than the Health Professions Educational Foundation, which two of our members, myself included, sit on. So as you go forward, I would hope that those people that are in charge of other programs or similar like programs would realize the opportunity of a conduit to information and hopefully maybe services from your community.
That would be great, because there are loan forgiveness programs or are loan repayment programs, things that are not the National Health Service Corps, but are other programs. There have been some recent grants, one to the state, in order to be able to utilize funds for various programs. So we should certainly take some time to look at all of those in the law. Happy to then sort of, take OSHPD and anyone else as a part of that so that everybody's on
Well, the object is to
right
be at
string.
least able to have a seat at the table, maybe not to take away any food, but at least sit at the table. So I appreciate your offer for that. And Dr. Salmonson has a question for you as well.
Well, I guess it's a comment that the projection is based on business as usual. And obviously, we can't have business as usual. And I'm sure you are totally thinking outside of the box in terms of how to deliver the care, because I wish that one-on-one health consultation could happen, but I think we have to have telemedicine, other ways of educating to get on top of that obesity thing. And I do some volunteer work internationally, and I was speaking to the Minister of Health of Oaxaca, saying, what is your biggest children's health problem? And I was expecting him to say infectious disease, and he said obesity and diabetes. So, it's not just McDonald's, because I didn't see a McDonald's sign there. So somehow we've got to get on top of that. And I think the burden of saying it's the primary care doctor who's got to get the immunization in, it's too much to just say, that's an important component, but I think we have to get involved with other providers, educators, whatever the initials behind their name. And in medical school, I have to say, I'm so old that we didn't have PAs or nurse practitioners, and so I don't even know how to take advantage of them except from what I've learned on the board. And I would say more physicians, I think, need to know what other providers are out there to provide better care.
And that's, I think, one of my personal hopes for the community transformation folks and the focus on population-based health, because I think we're trying to grow the capacity, we're trying to grow the workforce, yes, physicians, but all of the other providers as well, because of the expectation of 32 million people coming into coverage. I mean, in the state of California, we've had a couple-of-year debate about retail clinics and what they mean and whether physicians' assistants and nurse practitioners should be staffing those. Some have that model, some have physicians-only models, and all of those things. But I think that one thing that this law does is puts the infrastructure in place, puts the resources there to say, all right, let's look at these various things. We've been talking a lot in my office and throughout the region with a number of stakeholders, both governmental and non, about not just telemedicine, but about telehealth, because Orange County is a huge bastion of the medical device industry, which is a big part of telehealth. And certainly when you look at a California, when you look at a Hawaii, which I've now been all through doing outreach and education, Arizona, Nevada, there are significant issues around, well, how does the ACO concept work via rural area? I think you can organize yourself, but that organization, and if you join, still is probably through telemedicine. It's not like a medical center is going to be built moment one, and all of a sudden rural doctors are going to have access to these huge things. They may or may not want that. So it's a good point.
Dr. Giselle?
Thank you. Thank you, Herb, for a wonderful overview. I was wondering, what are your views on the recent 1115 waiver agreement that the state entered into, and what impact that it might have in fast-forwarding coverage for the uninsured in California?
Well, I think as a lot of folks have said, it's a really, really terrific thing and a great win for the people of California. The state brought forward the waiver discussion as a bridge to healthcare reform, as the delivery system bridge to reform. And I think that HHS, CMS, and the whole, if you will, not just the state, but the communities that were affected, tried the best that we could, and I think very successfully have put in place reforms that will, if you will, provide coverage for the uninsured, will provide coverage for the underinsured, but will do the things that it needs to do in terms of access, do the things that it needs to do in terms of the provider community, not just the consumer community, all of those things together. So I think there's a lot of work to do moving forward on implementation, but I think it's a terrific thing that the state and the federal government, with a lot of work amongst key stakeholders, non-governmental and governmental, coming through. And I've been honored to spend a lot of time with, various communities talking through just various aspects of what needed to be in that. My role was not as a negotiator. I took myself out of it when I was at the state because I didn't want to, if I had this job, have any sort of conflict. So this was the first that I actually had the ability to touch base with stakeholders. And so, we'll move from there. But I think it's a terrific thing and really does put California in a great place to be able to be successful in the implementation of reform. The state was exactly correct that there needed to be a bridge, and I think the stakeholder community came around and sort of engulfed that bridge in a good way.
Thank you.
Thank you. What I'm going to do is just go around the horseshoe so that everyone has a chance, and if you can spare a few more minutes.
Absolutely.
Thank you. Dr. Carrion, did you have any comments that you want to make to Herb?
Thank you, Herb, to be here. Thank you very much to be here. I get many questions lately about the accountable care organizations that everybody try to create their own. In the area where I work, the two IPAs that basically they dominate the area, now they try to move to these accountable care organizations. What is the situation for a solo practitioner these days? Because my understanding is that we are going to be an endangered species for the future if we don't become associated with these organizations.
Well, I think there are I think, that life evolves, and, for every person who has said to me that primary care physicians need to go join ACOs because there won't be small groups of doctors anymore, solo practitioners. I've had other people say to me, yes, there absolutely will, and it'll be here and there. So I think what the guarantee is is that regardless if someone's a solo practitioner in a small group or large, the focus is going to be on coordinated care and integrated care. The ACO model, we're currently developing the regs. I've come out everywhere to try and get input into that and continued input from folks. But I think I also recognize that people operate in different ways in different areas and different specialties. So the common thread is accountable, transparent, coordinated, integrated. But to me, that means you could use telemedicine to be able to do that. So I don't have a crystal ball and say, well, you have this amount of solo and small group docs now, and 20 years from now, what do you have? But I think we're trying to strengthen the role of the physician in the system and make sure everybody's coordinated. But I would encourage, the board, as well as I've been encouraging others, thoughts that you have about how ACO should be structured. There is a lot of openness in the statute around it lists for sort of different types of ACOs that there could be, but then it also says other things that the Secretary deems, appropriate to do that. We have the Innovation Center for CMS that's starting on January 1. That Innovation Center is a $10 billion investment, $1 billion a year each through 2019. That's going to be run by Rick Gilfillan, who's been the head of the Geisinger system in Pennsylvania. And that is an opportunity to not only test reimbursement, but to test service delivery. And so I think this is an opportunity for people to say, okay, well, are there some solo practice or small, group of solo practice that want to talk about, let's look at how do we do something like this in a rural area, in Medicare, or ultimately in Medicaid and the pediatric ACOs.
Thank you. Dr. Diego?
Yes. Representing the primary care, it's a really exciting place to be for primary care, to know that there's these many people, that much demand that's needed. So that's really great. The reality is, like Ms. Chang said, is that we're 15% and we'll soon be 30% short, and I've heard as high as 38%. So it's really challenging for sure. And we realize that the model, like Dr. Solomon said, has to change, because tomorrow, as these people start adding, we're not there. The changes that you mentioned are happening in medical school and residency. The pipeline, that takes about 8 years before we get there. In 2014, it's not 8 years from here. So from a primary care perspective, we're definitely looking at different models, definitely trying to push everyone to practice to the highest level that they can based on their scope of practice. So we certainly are going to be interested in looking at those different models, maybe as you find out from around the country that are working, so that we can bring them here. The one thing that we definitely want to protect, especially I think from the board, is that the quality of care that's delivered to Californians continues to be the same, even in these new models. So I think it's going to be really important to work closely, like you mentioned, collaboration. And then reimbursement for a lot of these things that happen. If you have nurse calls and even nurse visits and things like that, has the department thought about how you do that, especially like when you talked about solo practices and they don't have the monies to put this in, but you have to think about different things of how to deliver health care.
Yeah, and there are a number of demonstrations and pilots in the law using different types of providers. There's one that's a community collaborative network with groups in sort of underserved areas. There's one which is a pilot at home, which is a physician and a nurse practitioner model. So there are a lot of different things that we're looking at to try, but this is another reason for the Innovation Center, because I keep saying to folks, no idea to me is too big or too small. I was in D.C. a couple weeks ago for a retreat, and I got the opportunity to talk with Don Berwick, the new head of CMS. And so we were talking a lot about how can we as regional directors help bring some of those best ideas to the Innovation Center, knowing that, like Dr. Carrion said, the ACO concept, I spoke last week at the ACO Congress, and it was like, I must have heard 82 different models. And while that may be dizzying, to me, that's a good thing. That's like saying, okay, well, some things are going to work. We're finally saying, okay, there are resources there, because a significant part of this law is authorized and appropriated already, that we can be able to do that.
Thank you. Dr. Morand?
I have no comments, but thank you.
Thank you.
Dr. Israelian?
Herb, I just want to say congratulations, first of all, and this is a exciting time, I think, to be a provider, actually. I mean, and that's first and foremost, I think, the way I view myself. I think one thing, Dr. Carrion brought up a good point in terms of how an individual provider sees themselves fitting into this big picture. I think as you go, and this is more of a comment, as you go into the communities, because obviously when you're talking to these big organizations, sometimes individual providers don't really identify themselves as fitting into one of these organizations. And I think the important thing is trying to highlight opportunities for providers to partner with groups or programs that are successful or that have the means to be successful based on whatever kind of paradigm we end up following. And I think the providers just need to know that even if they are in solo practice, even if they have their established practice for many years, they can change gears to a certain extent, participate in this community effort without really impacting their own practice, so to speak, and still have a benefit for the greater good. So just kind of when you're going out, I think the individual doctors sometimes are going to be the ones that might not know how they fit in, and you might have to just focus in on them as well.
And I had a number of great opportunities to be able to do that. I always go into this when we started the Nunez-Schwarzenegger plan back in 2006, many of those provisions which are now in the Affordable Care Act, and even in this job, the way that I've approached this, I always say, having come at one point in my career from a trade association, I've always said to my trade association friends, no offense to you, we're coming to you to let you know that we're here, we're open, now where's your policy committee, where's your board, where's your community, because, when you get into the group environment in that way, it's the lowest common denominator, and the only way that I feel I'm going to effectively be able to advise the Secretary and the administration, and she expects that we're going to actively advocate for policies that we believe will benefit this country and this region. It's not just that we say we'll share the views and where do they go. She expects advocacy on those. So you're exactly right. And I had an opportunity. I was in, down in Riverside with providers through UC Riverside, and then very different in terms of people coming from areas. I was in Clark County doing the, Nevada State Medical Society meeting, and even though it was in Las Vegas, many of those providers were from, Reno, which is considered city, but way outside of any areas. Or I was at North Country Healthcare, which is an FQHC clinic system in northern Arizona, the only one. I think there's one other small one. And started talking with docs that have been in solo practice that still have affiliations with them but won't come in-house.
Great.
Thank you. Mr. Saronian?
Herb, I thought that we were going to connect to the White House again via teleconference. Great to see you again.
You too.
At the League of Cities, we had a teleconference.
And I should say, for those that are active there, I want to thank you, because we partnered with the California League of Cities, which became the first state association of cities and towns in the country to support a resolution urging all 480 cities in California to partner on Let's Move. And so we've been working throughout the region, California, but all of the other places. We got all 4 of the mayors in Hawaii signed up. Kauai, on Maui, on the Big Island, and on Oahu. It was nice. But anyway, but we got that. But so we've had great response, and I should say that because I know that Member Shipsky is on the City Council, and I know you're active as well.
My question to you, Herb, was we've tried at this board to look at ways of providing care or access to care, because there's a lot of degree of professionalism in this profession, as there is in my profession, but there's a lot of docs who want to serve their communities and want to be helpful and volunteer their time. I think what you presented, perhaps reducing redundancies between various forms of governments, perhaps could be a good way to look at allowing these volunteers to do their work, yet not fear the liability factor that they have had to fear for a long time. So the numbers diminish when, of course, you put liability forth. Anything in that domain that the Federal Tort Claims Act, for example, that comes to mind that you're working through that can be implemented in various states as well?
I think a lot of folks have started to mention it to me a lot. I actually was with a colleague yesterday who we were at this thing for the community health center, physicians and other providers in the region, and she came out from HRSA to talk about the FTCA. And it's one I think I'd like to get your views on. I mean, we've had that conversation a lot in California when we've had the various fires that we've had and some of the earthquakes, but when I was in both the Davis administration and the Schwarzenegger administration, we had, incredible retired physicians and other practitioners that wanted to help, and there were some real impediments to doing that. So I'd be very open to talking about it, be open to convening anything. There are some things in the Affordable Care Act around, liability reform. I'd have to check to see if any of those are specifically on that issue, but there was about $25 million spent on planning grants as well as other programs that were out. So I'd love to talk about it because I think it's been raised in all the places in the regions that I've been, including I've been on Guam and the Northern Marianas and Saipan. It's been raised there as well, given tsunamis and other things that happen in the Pacific.
Terrific. Thank you.
Well, I just would have to say, not just for the retired, because I think some people retire early because they say, I cannot take this risk any longer, So it's not just once they retired, but it could keep people in the workforce longer.
Correct. Thank you for pointing that out.
Ms. Shipsky?
Congratulations, and
Thank you.
I too was at the League of Cities conference, and Long Beach is one of the first cities that has signed on to the Let's Move.
I know, so thank you.
We're very excited about that. I'm really pleased to hear that, obviously as a nurse practitioner, that we need to talk more and more about a collaborative model of delivering care. Not just a coordinated, but a collaborative model. And I think that's important because the public needs to know that nurse practitioners, mid-level practitioners, do not want to replace physicians. They do not believe that they are physicians. That we do provide a nursing model of care that enhances the delivery of care. I think it would be helpful, though, if we really focus in on trying to standardize the entry to practice requirement, particularly for mid-level practitioners, and the educational requirements, because they've been, in the last 20 years, 15, 20 years, all over the map, so that you could get into it by various forms and educational requirements and still be called the same, which I know in the medical profession is a big concern because you have to go to medical school and the program is standardized. It has not been standardized so for mid-level practitioners. So I think that could be a big benefit down the line. I know that the nursing profession has been pushing for that, but quite honestly in California, we developed the AA degree for nurses because the hospitals had a shortage of nurses, and instead of having to have a diploma or a BSN, that's how we got a lot of nurses into practice. Consequently, you have nurses at different levels of education who basically can do the very same thing depending on if you have higher education or not. So I'm hopeful with some funding and really a focus in on how collaborative practice can actually increase access to care, that we can bring the mid-level practitioner to a standard level, and then I think that will help the comfort level, I think, on the medical side, because quality of care is the number one issue for nurse practitioners. And if medical malpractice records are any indication, they do practice very safe, quality care, and patients are very satisfied with the care. So I think we can learn from both models, but I think we do need to get this standardization moved forward.
Yeah, I appreciate you're saying that because I've heard a lot of different views, and I've talked a little bit with, some of my counterparts across the country. Many of us have sort of been talking with legislators and governors' offices and health commissioners in our states, territories, regions, about MPs, about PAs, about some of the differences. I was talking with some of my friends when we were in D.C. 2 weeks ago about the doctorate and nurse practitioners. I'm actually going tomorrow morning. I'll be in Oakland to speak with the California Academy of Family Physicians, but then I'm going to be speaking with the California Academy of Nurse Practitioners in the afternoon. And so I do try and get out far and wide and get the diversity of views, but I'll probably follow up with you because it's interesting to see all of those state variations and how they're sort of impacting what gets done or what doesn't get done in that. But I don't know that there are things in the Affordable Care Act that address it, but there's always time for a larger conversation about that.
Well, I want to take this opportunity to really thank you, Herb, for taking the time to join us this morning. And I would look forward to the ongoing dialogue that we will be able to have, and maybe even hopefully a link at some point from your website to either best practices that are going around within your purview or information that might be valued to people on this board as well as to people in the greater community. And thank you very much.
That's great. I'll leave enough cards for all of the board and the staff, and you've got that up there for the audience. But we encourage folks to get onto our list because at least it is a great way. I'd be remiss if I didn't say the website that the department has built is very historic. It's called healthcare.gov, all one word, healthcare.gov. We now have an all-Spanish version called cuidadodesalud.gov. And we were at Ultimed with the Hispanic community, Dr. Carrion, 2 weeks ago now, with the director of White House Intergovernmental, Cecilia Munoz, talking about cuidadodesalud.gov and how to be able to use that in various communities. And we're obviously working with various communities to get help from the API community and others to translate, sort of key parts of that. So anyone can feel free to call me, email us, we'll get you on our list.
Thank you very much.
Thank you.
What we're going to do is take a 5-minute break. It's 10:20, so we're going to start back at 10:25 with number 18.
Any quick question? So, things that nothing was not yet.
I do.
Do we have quorum now?
So do we have a quorum now?
Yes.
Okay, it looks to me like we have a quorum. I'm just looking for that.
I think.
Good morning. My name is Barbara Yaroslavsky, President of the Medical Board. I will be presiding over these hearings. Today we have 3 rulemaking hearings scheduled. So I do not have to repeat myself each time. Let me discuss the format that will be followed for each hearing only once. Then we will move into the 3 individual hearings. We ask that persons in attendance print their names on the roster at the room's entrance. If you wish to testify, please indicate that on the roster sheet. The purpose of each hearing is to receive oral testimony concerning the regulatory proposals described in the notice. Regulations must comply with 6 legal review standards, which are: necessity. Is there a demonstrated evidence that there is a need for the regulation? Authority. Does the board have does the board have legislative authority to adopt the regulation? Consistency. Does the regulation conflict with other regulations or statutes? Clarity. Can the regulation be easily understood by those affected? Non-duplication. Does the regulation duplicate other regulations or statutes? Reference. Which statute does the regulation implement, interpret, or make specific? Testimony must be addressing one of these 6 standards. Before we begin, I would like to briefly describe the procedures that will be followed at each hearing. The entire hearing will be tape recorded. Those persons testifying will not be sworn in or cross-examined. All recommendations and objections will be considered by the board members. Responses to all objections or recommendations will be included in the final statement of reasons. The board will maintain a rulemaking file of this proposed regulatory action. A completed copy of the rulemaking file will be available for review at the Medical Board's office in Sacramento. To ensure fairness and that everything is completely entered into in the record, and to enable everyone to hear those who are giving testimony, we ask that those testifying follow these procedures. Please speak loudly and clearly. Identify yourself and who you represent. Please state your position, support or oppose, at the beginning of your testimony. Oral testimony will be limited to 5 minutes per person. Please do not repeat testimony already given. Any written comments you have with you today should be summarized orally but should not be read. As I mentioned, we have 3 hearings scheduled today. In the event that the board wants or needs to take a recess, the hearing presently taking place will be concluded in its entirety. A final discussion and vote will take place. Only then between any 2 of the 3 hearings might a recess be called. Now let's move into the first hearing. Mr. Hepler and Mr. Worden, thank you for being at the table. This is the time and place set by the Medical Board to conduct a public hearing on the proposed regulation to adopt sections 1315.50, 1315.53, and 1315.55 of Title 16 of the California Code of Regulations as described in the notice published in the California Regulatory Notice Register and sent by mail to those on the board's mailing list. This regulatory proposal sets forth the requirements and criteria for the Medical Board to issue a limited practice license to an applicant who is otherwise eligible for medical licensure in California but is unable to practice all aspects of medicine safely due to a disability. In preparing the regulatory language, staff also considered current licensees who wish to go into this status due to a disability affecting their ability to practice some aspects of medicine safely. Parallel language also was prepared to ensure the limited practice license is consistent with the criteria for the current disability license. Written comments for the regulation being heard today must have been received by the board at its office not later than 5 p.m. on October 25th, or must be received at the hearing. For the record, no public comment was received by the deadline. For the record, today's date is November 5th, 2010, and this hearing is beginning at approximately 10:40. After our legal counsel's opening statement, I will call on those persons who want to testify. Mr. Hepler or Mr. Worden, do you have any comments?
The board did not receive any written comments on this proposed regulation.
Thank you, Mr. Warden. Madam President, members, just to reinforce the concept that the President has already mentioned, these regulations, I'm sorry, too many moving parts. These regulations address both those who seek an initial limited practice license and those licensees who may be currently on a disabled license status and wish to seek a limited practice license coming off the disabled license and seeking the limited practice license. These requirements would be enforced for both.
Thank you. I have no public comment slips for anyone wanting to speak on this issue. Do I have any comments from the board? So, excuse me, I'm going to close the hearing and ask if there is anyone else who wishes to testify. Since no one is asking to speak concerning the board's limited practice license, we are going to move on. I need to have a motion to adopt this, please.
So move.
Have a second?
Second.
Any public discussion? Any members' discussion?
I guess I haven't, frankly, read through it in its entirety. It just occurred to me, I understood the initial application, and I guess then there's a different thing about renewals because medical conditions could change. Is there a different process for renewing the limited license?
Not for renewal, no. This is, like I said, two things. One is the initial, and one is if a licensee currently is on disabled status and they wish to change or revise that status to come into the limited practice, this would govern regarding getting an independent clinical evaluation for the board to evaluate coming off the disabled and moving to a limited practice license. But the renewal is unchanged.
So, okay.
What it means is that the current law allows licensees to go into disabled status, which means they cannot practice. They can come out of disabled status. This would, with the appropriate information from the reviewing physician, this would standardize it so that both the person seeking the initial license and the person seeking to come out of disabled status would have the same requirements apply to both. But it's not tied to the renewal.
Okay, but now somebody has a limited license so they can practice. But what is their renewal process like?
It's the same as any other physicians.
Oh, so they don't have another mandated exam. It's a one-time deal?
Right.
This is basically, Dr. Selmanson, for someone who has a specific issue that doesn't allow them to practice specifically with regard to that issue that they might have, some kind of physical impairment.
No, I was just concerned that might be a changing situation, so that a one-time exam, is that enough?
If the situation changes, then the applicant can request a full and unrestricted license, but they would have to go through certain steps to get that. And that would be their call. Yes. There would have to be an evaluation by a reviewing physician that substantiates the physician's ability to practice safely without restrictions.
I'm just wondering the reverse, if they would acknowledge if their condition had deteriorated to a greater degree, and that was my concern, the flip side of that. But
that's a different kind of an issue.
Okay.
Barbara?
Dr. Carrion?
My understanding is that you practice medicine or you cannot practice medicine. Can you give an example when a doctor is limited?
This is a doctor, for example, who might be blind, who might opt out of being able to practice surgery, but would be more than competent and capable of doing other forms of practice. Pediatrics possibly, psychiatry possibly.
But blind?
That's exactly the issue.
Well, the issue is, you could be a psychiatrist, yeah.
All right.
The issue is that a doctor previously coming into the situation who, because of one sort or another of infirmity, was not able to get any other license other than one that seemed to have a discipline issue, so that the probationary license that was being issued put them into a category of being on probation, which quantified them as not being able to get malpractice insurance, or their rates might be higher. So this is taking a doctor who's more than competent to be a doctor. Cerebral palsy, blindness, there's all sorts of different situations. We don't have that many. But this would, pardon me? Loss of a limb. Something that would allow the doctor to continue practicing in a specialty that wasn't at risk by virtue of the fact that the person's infirmity exists.
And as long as the liability is not very high, right? Because a person who is limited and is practicing any type of profession is going to create some liability.
Granted, we don't have, as you know, in California, we don't offer licenses in specific specialties. You're licensed to practice medicine at large. But this would give the doctor, who is in fact a more than competent practitioner, but through some issue of disability, would give them the opportunity of having a license that was limited to the abilities that they can perform, but not put them into a disciplined situation which would impact their insurance carriers' availability to give them insurance. We have very few of these, but this is to protect them. And we've had a situation with doctors who have had some sort of infirmment. I don't know what the appropriate term is, so I apologize. I'm stumbling for the politically correct term. But situations, so this is to protect them, as well as the public.
Right.
The public will know as well.
These regulations are specifically authorized by legislation that was passed, I believe, a year or two ago.
Correct.
So I would like to call the question. All those in favor of the motion of the regulation as stated, say aye.
Aye.
Any opposed? Okay, so be it. Now let's move on to the second hearing. At this time and place set by the Medical Board to conduct a public hearing on the proposed regulation to adopt Chapter 3.5, including the numerous sections of Title 16 of the California Code of Regulations, as described in the notice published in the California Regulatory Notice Register and sent by mail to those on the Board's mailing list. Among other things, this regulatory proposal sets the qualifications for certified polysomnographic technologists, including requiring those technologists to be credentialed by a board-approved national accrediting agency, have graduated from a board-approved educational program, and have passed a board-approved national certifying exam, with a specified exception for that examination required for a 3-year period. Written comments for the regulation being heard today must have been received and must have been received by the Board at the office not later than 5 p.m. on October 25th, 2010, or must be received at the hearing. Those comments, which were received before the deadline, were given before this meeting to the Board members for their review. For the record, today's date is November 5th, 2010, and this hearing is beginning at approximately 9:50. Do all the board members have the copies of public comments which were received by mail last week? I assume so. After our legal counsel's opening statement, I will call on those persons who want to testify. Mr. Hepler or Mr. Warden, do you have any comments?
Thank you, Madam President and members. Unlike the previous set of regulations, this regulation did receive substantial public comment. Ms. Scurry and I, legal counsel for the board, have reviewed these. We believe there are 4 revisions that based solely on a legal perspective that make sense for the board to consider. I'll start off with page 1 under 1378.1 of the definitions, subdivision D. After doing some
Mr. Hepler,
Yes.
could you identify the page number in the packet, please?
Okay, I'm working off something a little bit different. I apologize. 110. No, I'm sorry, that's incorrect. 123.
Where's 123?
123, page 1, subdivision D of the definitions. Okay. After doing additional research, we found out that there were essentially 2 examinations offered, and so we would recommend that the board clarify which examination. So subdivision D would be proposed to be amended to read, quote, National Certifying Examination, unquote, means the technologist credentialing examination given by the Board of Registered Polysomnographic Technologists. I know what you're thinking, that's easy for me to say.
I think that's someone else is having trouble with these words.
And then skipping to page 6 of the proposed regulations, this would be page 128. And about 4 lines down from the subdivision B, which actually starts on page 127, but for the purposes of our amendments, we'll talk about page 128. Starting off with the second part of line 4, we propose to amend to read as follows. For the purposes of this article, striking section, other licensed healthcare professional means insert a, so it means a registered nurse, physician assistant, strike the and put or respiratory care practitioner who possesses a California license. These are the sub and substance of the edits of the revisions that your legal counsel believe necessary to satisfy the statutory standards for adoption of regulations articulated by you, Madam President, in your preamble.
Now I have some public comments. I do have some public comment slips. So I'm going to ask the first one, David Gonzalez and Dr. Selecti. I apologize if I'm butchering your names, I know, but I can't read them either. So please come forward. They're from the California Sleep Society.
You pronounced Gonzalez quite well, so thank you.
That's an easy one.
Thank you, members of the board. David Gonzalez, today on behalf of the California Sleep Society. CSS is the trade association representing the physicians and the health professionals that practice sleep medicine in California. We're the sponsors of Senate Bill 132, the enabling legislation for these regulations. And what I'd like to start out saying is that we remain very pleased with the board's work on these regulations. We do have some comments, and we submitted comments earlier, but we do have additional comments that reflect mainly the comments that were received earlier, but there are some additional comments that we'd like to put on the record that we feel are important, but we'd like to submit to you. So I'm not sure who I should give these to.
Mr. Hepler?
Certainly. But again, you're creating a new certifying scheme in the state, so this is a very complicated program. And when we saw the first draft of the regulations, we were very pleased with the regulations. It's a very complicated scheme, and you've done a very good job of creating the framework of how to implement Senate Bill 132, and we're very appreciative of that. And we simply ask for some additional time to work with your staff to work out some of the additional details that we have regarding the regulations. And we hope that we continue to work with you on implementing Senate Bill 132. And I have with me Dr. Paul Selecki, board member of the California Sleep Society, and I'd like, if it's okay with the board, to have him introduce himself.
Good morning, and thank you for giving me this opportunity to comment. I'm a board-certified pulmonologist and sleep physician based at Hoag Hospital in Newport Beach. We represent the California Sleep Society, who is a professional society devoted solely to the evaluation and treatment of patients with sleep disorders, both sleep technologists as well as sleep physicians, and appreciate the opportunity to answer any of your questions.
Do any of the members have questions to these gentlemen? Thank you very much for your remarks. I also have a speaker's request from Stephanie Nunez. Another easy name to pronounce.
Good morning, Madam President and members of the board. I thank you for giving us the opportunity to make public comment on these regulations. I have a statement here that will take far less than 2 minutes. I'm just going to read from it. Did I mention who I was? I'm sorry. I'm Stephanie Nunez. I'm the Executive Officer of the Respiratory Care Board. As you may be aware, the Respiratory Care Board has long been a proponent for regulating polysomnography technicians. After a hearing before the Legislative Sunset Review Committee in 2001, the board began researching what it believed to be the unlicensed practice of respiratory care as it relates to polysomnography. As a result, the board was deeply concerned for public protection, especially as it related to incompetency and criminal activity in connection with sleep labs. We did submit written comments previously, and we have a few additional comments to add to these. Actually, my board president thought it was very important that I be here today to stress these comments. Subdivision B of Section 1378.9 allows a person to grandfather into the practice based on a physician declaration that the applicant has practiced safely for 5 years. Our board is requesting your consideration to require applicants to successfully complete the BRPT examination. Last time I checked, there's only one formal college education program in California, and the on-the-job training can vary a lot from hours to the depth of kind of training that they get. That, coupled with the patient harm that could be prevented, are important factors to be considered. We appreciate the fact that a grandfather clause is a common practice of newly regulated fields. However, given the infancy of the field and our highest priority of consumer protection, we believe passing an exam to demonstrate minimum competency far outweighs any benefit of allowing a free pass to new applicants. The second issue we had is Section 1378.13, which allows physicians, RNs, physician assistants, and RCPs, and polysomnographic technologists to provide supervision. Our board is requesting your consideration to only allow properly licensed physicians and respiratory care practitioners to provide supervision based on the propensity for respiratory-related emergencies to arise. Many sleep labs are connected with acute care hospitals, but there are even more that are established independently without any government oversight whatsoever. They're testing in hotel rooms and private homes. All of these unregulated sites could be miles from an acute care hospital should an emergency arise. Therapeutic intervention through the use of CPAP and BiPAPs is common during sleep studies. RCPs are specifically educated and trained in respiratory care and are the most qualified personnel to recognize and respond to hazards and complications that will arise from such. There are numerous contraindications related to the use of CPAP and BiPAPs. It appears there are no questions on the BRPT competency exam dedicated to responding to the contraindications, and only a handful related to responding to medical emergencies in general. Without significant education and training, a registered polysomnographic technologist is not equipped to respond to such contraindications such as hypoventilation, hypercapnia, barotrauma, gastric distension, and the list goes on. The board found that the unregulated settings for sleep labs and the overwhelming number of uneducated sleep personnel with limited on-the-job training were creating the perfect storm. However, we believe you are at the threshold to providing a great service to Californians by moving forward with implementing SB 132 and protecting consumers. We sincerely appreciate all of your and your staff's hard work on this issue, your time today, and your consideration of our comments. Thank you.
Thank you very much for your comments. You should know that the first part of what you read to us is what is in law currently.
Thank you very
Okay.
much.
So the hearing is now considered to be closed. And if the members have any questions or would like to make any points, they should do so now.
So I'm just for clarification, have we incorporated the comments in these regulations, or are there still issues that the sleep specialists don't feel are revised regulations? Because I thought I heard them say they'd like opportunity to work with staff to further refine the regs. I mean, are we? Because I would respect the experts, wanting the wording to be absolutely optimal for patient protection.
I would agree with you, but I would venture to say that we are also in the situation that this has been a long time coming, that it's maybe better to get this moving forward, and then as we see where there needs to be improvements made, let them come back and tweak it.
Because I guess the biggest concern I had was, do we have that grandfathering in? Does that stay in, or we want to require the test or not? Seems to me that's where I'm seeing the biggest discrepancy.
The grandfathering in is actually a function of law, not these regulations. So there's very little the board could do as far as the grandfathering. Just for parliamentary procedures, we have, notwithstanding what was said about the Sleep Society with the new things, we have the proposed amendments Ms. Gray and I have are a basis of our review from a legal perspective, not necessarily a policy perspective. So I'll leave it with that. And we're proposing probably a 15-day notice to go out and effect those changes. So for your consideration.
This bill was requires regulations to be drafted within 1 year from the effective date, and the bill, I think, was urgency legislation, and therefore it took effect last October. So we are at, basically, graciously speaking, the end of our 1 year period. So while further refinements may be possible, and it is your call whether you wish to accept any of the other comments and make changes, we have not, Mr. Hepler nor I we have not stepped into the policy arena. We simply recommended the changes that we felt were necessary for legal clarification. So, and as Mr. Hepler mentioned, the grandfathering in lieu of an exam is in the law.
Okay.
Okay, so I need a motion to accept the regulations as amended.
Well, actually, it's a little more complicated of a motion, if Mr. Hepler will indulge me. The motion would be to authorize the executive officer to adopt the regulations as modified at the expiration of the comment period if there are no adverse comments. Because if there are adverse comments, OAL will not accept them. It will have to come back to you. So that would be our recommendation for a motion.
Okay, so move.
Second?
Second.
Any board member comments? So all those in favor of the motion as it's stated by Ms. Scurry, please say aye.
Aye.
Any opposed? Thank you very much. Now let's move on into the third hearing. Ms. Scurry and Ms. Katie, would you please come? Oh, Ms. Katie, you'll stay here. Come forward, please, Ms. Katie. This is the time and place set by the Medical Board to conduct a public hearing on the proposed regulation to amend Section 1361 of Title 16 of the California Code of Regulations as described in the notice published in the California Regulatory Notice Register and sent by mail to those on the Board's mailing list. This proposal will amend our regulations which incorporate by reference the disciplinary guidelines entitled Manual of Disciplinary Guidelines and Disciplinary Orders. These amendments are being made to keep the guidelines current and useful. Written comments for the regulation being heard today must have been received by the Board at its office no later than 5 p.m. on November 1st, 2010, or must be received at the hearing. Those comments which were received before the deadline were given before this meeting to the Board members for their review. For the record, today's date is November 5th, 2010, and this hearing is beginning at approximately 11 o'clock. Do all members, Board members, have a copy of the letter from the California Medical Association which was distributed?
Yes.
Thank you. After our legal counsel's opening statement, I will call on those persons who want to testify. Ms. Scurry, Ms. Katie, do you wish to have any comments about this regulations in general?
Yes, you should have in front of you a handout for Agenda Item 20. And this is a suggestion for a change to one of the disciplinary guidelines. It's Condition 33, non-practice while on probation. Last week when an issue presented itself, it was clear that one more section ought to be added to the current proposal. This proposal combines the two prior terms regarding non-practice in-state and out-of-state. And it allows time spent in an intensive training program not to be considered non-practice. If you're allowed to practice in another state while you're in a residency program, we felt that it was important that that program be notified of your probation in California. So even though you might not have to comply with any of the other terms and conditions, there are certain ones that you're still required to comply with right now, which are obey all laws and the general probation requirements. And to this, we would propose you add the notification provisions. Ms. Katie may have some other comments. I don't know.
Ms. Katie? Now I will call upon those persons who wish to testify concerning this proposed regulation. The first person is Ms. Julie D'Angelo Feldsmith. If you would come forward, please.
Good morning. My name is Julie D'Angelo Felmuth. I'm the Administrative Director of the Center for Public Interest Law at the University of San Diego School of Law. Just some brief background for the newer members. In 2007, as most of you will recall, this board unanimously decided to end its diversion program for substance abusing licensees after that program failed 2 performance audits in a 2.5-year time period. Thereafter, you removed participation in the diversion program as a condition of probation, and you replaced it with requirements regarding abstention from drug and alcohol use and random drug testing. In 2008, the following year, the legislature passed Senate Bill 1441. Among other things, that bill required the department to convene a substance abuse coordination committee and charged that committee with developing, and I will quote from the statute, uniform and consistent standards that each healing arts board shall use in dealing with substance abusing licensees, whether or not a board chooses to have a formal diversion program. Now that committee was established. It met throughout 2009. It finalized its guidelines in April 2010. And my understanding is that committee does not intend to meet again during this administration. I'd like to address some consistency issues that Ms. Yaroslavsky outlined. These disciplinary guidelines, just a few of them, are not consistent with the uniform and consistent standards that have been adopted by the department committee in a couple of respects. Your uniform standard number 8, adopted by the DCA committee, says that when a licensee tests positive for a banned substance, the board shall order the licensee to cease practice. The board shall contact the licensee and instruct the licensee to leave work. And the board shall notify the licensee's employer, if any, and worksite monitor, if any, that the licensee may not work. This is very similar to what your prior diversion program purported to do. Immediately remove that licensee from work upon a positive test. We found that it didn't always do that, but that's what it said it did. Additionally, Uniform Standard Number 10, adopted by the Department Committee, classifies a positive test as a major violation and requires the board to order the licensee to cease practice. So that's what the Uniform Standards adopted by the Department Committee say. Your proposed conditions 9 and 10, and to a certain degree 11, state that the board should notify a probationer who has tested positive for a banned substance, that is, committed a probation violation, that he or she must leave practice after 3 days. I submit to you that that does not protect patients from a substance abusing probationer who has demonstrably relapsed, and it is not consistent with the uniform and consistent standards that have been adopted by the Department's Committee. Similarly, Uniform Standard Number 4, adopted by the Department's Committee, established drug testing frequency. And that standard requires a substance-abusing probationer to be tested 104 times during the first year of probation. That's 2 times a week. Your condition number 11 had 4 times per month in it. But now that frequency is being deleted entirely. That condition number 11 is not consistent with the Department's uniform and consistent standard number 4. Now, I just want to reiterate, Senate Bill 1444 does not say that the Department's Committee should adopt minimum standards below which no board can go and above which all boards can do whatever they want. The statute specifically says that the Department's Committee should adopt uniform and consistent standards that all healing arts boards shall use in dealing with substance abusing licensees. I have one additional comment on your condition number 11 regarding biological fluid testing. Remember who we're dealing with here. We're dealing with a confirmed substance abuser who is being publicly disciplined and who is being required to undergo drug testing, random drug testing, as a condition of being permitted to practice medicine. This condition says that the licensee has to arrange for drug testing within 30 days, 30 calendar days of this decision. To me, that allows this doctor to practice for 30 days without any drug testing. I think you should make the arrangement of drug testing a condition precedent to return to practice. That means no practice until the drug testing at the required frequency has been arranged to the satisfaction of the medical board. If we were to modify that condition number 11, you could make it look like option number 1 under condition 17, which is on page 177 of your materials. That establishes arrangement of drug testing at the required frequency as a condition precedent to returning to the practice of medicine. Thank you very much for your consideration of these comments.
Thank you. I would like to ask Ms. Kirchmeier if she would come forward just to clarify what I heard, that there would be no more meetings of this committee, as well as standard practice that's expected.
In regards to the meeting, there was a subcommittee that was established to look at the number of tests that were being required, and I believe it's number 4 of the uniform standards. That subcommittee, unfortunately, there was an issue with the noticing of the meeting, and it did get canceled. I believe it was set in September, and there has not been a meeting scheduled that I know of in the future yet. So I'm not sure if the meeting is going to be held again at this time, but if the meeting was scheduled, then they'll go forward with it. But as of this date, there hasn't been another date set for that subcommittee meeting. So at this time, the requirements as how they stand in the April 2010 version do state the 104 times for testing.
So that the number that's in place currently is 104?
for the first year. It's 104 for the first year, and then after that it's 50 times. But again, the subcommittee, we have said the chair of the committee is actually the director, and he has set up and established a subcommittee that will look at that number of testing, because there had been discussion at the prior subcommittee meeting that that number wasn't validated. So they are still looking at that number of testing. However, as they stand right now, it is at 104.
If I may. At the April meeting, there were a number of the members of the committee that were concerned about that particular number and asked that a subcommittee be formed to examine it and look at the real data behind the need for 104 tests, or how many tests would be appropriate, and that was deferred then to the subcommittee, and that subcommittee again was scheduled to meet and has not as of yet. So that is, as the committee felt, an outstanding issue that has not been fully resolved, because it was put out there as something that still needed additional work.
Dr. Selmanson? Do you have a question, Ms. Kirchner?
Well, yeah. Would you suggest, or whoever wants to field it, that we have our number and say, or the final recommendation by this subcommittee?
There are other boards that are moving forward with the caveat, with the thought that they can go back and amend their regulations from the 4. I don't know, from legal counsel right now as it stands for your board, you could require the amount of testing, I believe, based on what's written in there, but again, you wouldn't have specifically in your regulations the 104, unless I'm not correct with that, Anita.
Do you want to say that all over again? Because I'm not sure I understood. Are you suggesting they should modify the regulations to put the 104 number in?
What I'm stating is the way you have it written right now in your regulations, I believe you would be able to test to comply with those statutes.
Yes, they could test to comply with the statutes. I don't recommend that at this time you change the regulations to put a number into the regulation. Partly because it doesn't sound like it's a fully resolved issue. Ms. Felmuth did point out that there are several other inconsistencies between the SB 1441 standards and these particular regulations. Perhaps after you hear the rest of the public comment, then we can give you some advice.
Do you want to make another comment?
Yeah, can I just go? And I would also recommend that they do come into compliance. That is one thing we're asking the boards to do, to bring their disciplinary guidelines into compliance with the uniform standards. I believe there's also an evaluation, and I'm not sure if it's not in here, and that was another part of the uniform standards. In looking at some of the other boards and the way they've put them in, they have kind of set them aside and separate in their evaluations. One other item I did want to point out is that in regards to the testing, the cease practice and the suspension of the individual, you may wish to include in your authority now 1172. I know it's not effective yet, but it has been chaptered, so I don't know if you could put that in there to help back up your suspension of a licensee who's found to be in violation of the law.
Can't really put it in and reference it until it's effective.
Okay, I didn't know.
Okay. Is there any other question directly of Ms. Kirchmeier? Okay, thank you very much for that clarification. Ms. Chang, did you have a comment? Okay, I'm going to ask for the other public comment. Stan Formansky, Dr. Formansky, if you come forward, please.
This is on the disciplinary guidelines or the suggestions for changes. It actually includes, I think, the model orders too. But anyway, there's 2 points I want to make. One is about ex facto protection of the doctors. All of your 100,000 doctors have protection under the ex post facto provision of the law, which says if you try to enact a regulation and then make it retroactive, you can impair their rights. I have a very simple solution to that, to clarify that you don't want to take these regulations and say, well, so-and-so now you're in violation of the your 3-day notice or something like that. My suggestion, I prepared it in writing that you can receive it if you'd like. It says as part of the ex post facto rights of the licentates, that's your doctors, it's the board's intent that no change in the guidelines or the model order should be used to detrimentally affect any licentate who has an order or a stipulation issued prior to the effective date, and that would be in 2011. This wouldn't take effect until the Secretary of State approves it or files it, and 30 days after that. This is a very simple fix. If you can't make the fix, probably problems will happen. Somebody may challenge all the guidelines that you have in your model orders on the fact that it doesn't give the protection. That's a very simple fix. I'd like to submit this it's handwritten and very simple. It's one sentence that would give some protection. That is a constitutional protection, which your doctors are entitled to. Me and you and all the doctors here have that right. But if you look at what you've done with the model, with your proposed changes here, your changes, I understand that your addition number 10 went down in flames, that it didn't pass the OAL, the Office of Administrative Law, and it never got approval of the Secretary of State as of June or August of this year. So all those changes never took effect. As I understand, they're a nullity. What you're doing now is coming back with, and I see 37 pages and like 100 different changes in your regulations. It may be unclear to, for instance, your employees who are working in the probation offices whether the current regulations that you're trying to enact today apply retroactively. Do they, don't they? I'm saying that they can't because there's an ex facto protection. Let me finish my comments now as far as the second thing. Your proposed regulations as they stand now do not take into, they say they have lots of regulations and lots of new times and dates and stuff like that you can't apply them retroactively, like there's some kind of 3-day, can't practice after 3 days. Well, that wasn't the guys who made stipulations 4 years ago. They never saw that. They couldn't have taken into consideration. It's a material fact that they never saw. So it's protected by ex post facto. The suggestion I'm making here as my second point is that there is nowhere in your regulations a grievance procedure. Let's say somebody says, well, I never got notice and I'd like to have talked to somebody about the problem, or you say this, but it's not really this, it's not A, it's B. What's the grievance procedure? Since you have some time, I would write in a grievance procedure. There's 4 or 5 different ways to do it. I'm not going to waste your time suggesting you could have non-binding arbitration.
Dr. Fermansky, you need to wrap this up, please, and you can give your written comments to Ms. Thompson.
I will. In 30 seconds, I'll tell you about a case. It's called Platt versus Schwarzenegger. It's in healthcare. One of your other sister agencies in California was sued for not having a grievance procedure by the patients. They said the doctor's not listened to us. We can't get medical care. They appointed a receiver who's been in force for 5 years now. And it's now case law in the Ninth Circuit or whatever the San Francisco Circuit is, Platt versus Schwarzenegger. It says the agency had a duty to give a grievance procedure and they didn't. So we're appointing a receiver to take over that, whatever responsibility that was, as well as the health care delivery part. And that's the law. That's case law now.
Dr. Fermansky, it's more than 3 minutes. Thank you for your comments.
Thank you. I don't know if I give it to you or who.
Just for the record, regulations are never applied retroactively. It's not possible to change the terms and conditions of someone's decision to include any of the changes that are made here today. They are specifically prospective in nature.
Are there any other comments from board members? Seeing none, we've now closed the board hearing. I'm going to ask that staff come back to us, that we not approve this regulation at this time, that we come back at the next meeting in January with regard to the standards, 1441 standards and whatnot, and to make sure that we need the Office of Administrative Law to approve this, what we've done, and I'm afraid it's not going to happen if we've got any conflict in it. And since we have some, that would be my recommendation. So I'm going to ask for a motion to table this, please.
So moved.
So done. Okay, so we're going to...
We already made it.
I was under the impression, I apologize, that a motion to table doesn't need a vote. But you would prefer to have a vote? All those in favor of the motion to table, say aye.
Aye.
Those opposed? None. So done. So now we're going to move on to number 21. soon as I find my place, we'll start on number 21, which is my report on interested parties. I really have nothing to report, given that I was laid up for a good part of this quarter, so I'll defer to members if they have anything to report with regard to any communications with interested parties to so say, and I don't see that anyone is raising their hand. So let's move on to number 22, my report. I participated in 3 August, September, and October hour-long monthly conference calls with the director, his deputies, Healing Art Board's presidents, and executive directors. We had updates on the budget, personnel, CPEI, and an exemption request, drug testing by Maximus, or lack thereof, meeting protocols, healthcare workforce statistics, and a roundtable discussion on best practices by boards. I want to say that we and our staff have some of the best practices in this department. I attended the Midwifery Advisory Council meeting in August and toured the licensing section. I attended the Physician Responsibility Committee meeting on October 20th to hear the presentation by the Nursing Board and Physician Assistant Committee, as this was of interest to the Education Committee too, and we did not want to repeat any presentations. And I thank Dr. Moran for her extraordinary efforts in making this such an informative meeting. Moving on to oh, my apologies. Okay. But can I finish the sentence? Thank you. I also have established some new committees and appointed committee assignments. I want to thank all the board members around this table for their willing to step up to plate and participate. It's really most helpful. If we had more members on this board, we would have less opportunities for you to participate. So you're all doing more than your fair share. And I apologize. It seems that we do have public comment number 21. And number 21 was interested parties meeting, so my apologies. Did I forget to say I met you in August, sir? Oh, I did. Please have a seat at the table.
Sorry.
Thank you.
Good morning. I'm Leonard Sclafani from American University of Antigua. I don't want to take up much of your time, but in this issue, we have an item on the agenda. It's item number 28. We just happened to find out about it because we sometimes check the agenda, and a consultant told us about it. It seems that in addition to the criteria for notice here that you set forth in the document, when there's a party who has a particular interest, perhaps somebody who's appearing for licensure has an issue, a school that's looking for approval in our case, that specific notice should go to that individual or that body and shouldn't have to rely on a public notice, especially because they may not be in the state of California.
I can appreciate your concern, sir, and coming from New York, I understand that very well. This is just an update. It would be in the minutes. It's not like...
It doesn't matter. It's not about this particular issue. It happened in this case. It may be an update, but we have some comments that we would have, and the regulation, as you have it spelled here, would apply even when some drastic measure was taken against a body or an individual. They should get specific notice of that.
Might I suggest, as I will to everyone sitting in the audience, that the medical board has a phenomenal opportunity of sending alerts and notification to interested parties. I get them on a daily basis. Might I suggest that you and interested parties from the East Coast might want to sign up for that, and then you'll receive those updates automatically, that we can go through a board agenda and start noticing anybody that might be interested in anything that we're going to be discussing. We're going to miss someone anyway. So this way it's a proactive opportunity on your behalf and your school's behalf to be getting regular notifications. It just comes that it'll come as an email. It'll come... Check on the website. There's a notification of information that might be pertinent to your cause.
I appreciate that. I think in most instances, an individual might only have one particular reason why he wants, and he doesn't want to get flooded with every notice that the board happens to issue. He may be somebody up for licensure, and all of a sudden his name will appear on a meeting, and he won't know about it unless he happens to be checking these things or getting flooded with emails. It seems that due process should require that the board give specific notice to people who are specifically mentioned in the agenda.
Okay, thank you very much. Is there any other public comment that I might have missed on 21, 22? Thank you. going to move on to number 24 and ask for Ms. Whitney to please present her Executive Director's report.
If you will all please turn to page 199 of the agenda packet. For the current year, we are projected to have a surplus of $24 million in the fund, or 5.3 months of the reserve, slightly in excess of 1 month as permitted by law, which is the 4-month reserve. This may increase depending upon the outcome of labor union agreements that end the 3-day per month furlough program. In addition, there will be a 5% salary savings cap that will be incorporated. This could offset proposed augmentations, as you'll notice in the budget year, that have been requested but denied, but we will be seeking in a spring finance letter from the new administration concurrence with our augmentation requests. We were very disappointed that these did not go forward in the current administration. If these augmentation requests are placed back into the budget, it will offset any reductions that we foresee. Thus, we are not ready to address any type of reduction in the fund condition until we really know more about our operating costs and what will occur in this next administration. We implemented a potential long-term expenditure saving program with the email blast to 96,900 licensees with our October newsletter, thus saving both printing and postage costs by 2/3. We do not have an analysis of how this was received at this time. We only received 1,100 emails returned to us that were bad addresses, and we received 900 requests to have a printed copy sent to the individual instead of the email copy, and that has been complied with. As we continue to go green, we will be surveying our major medical associations and groups to determine if this is working out for their membership and if there are any concerns with sending our newsletter via email to notify our licensees of various pieces of information. But we really see this as a major benefit in our cost saving and going green with this medical board. In addition to going green, at our next meeting, we will be testing a thumb drive option for those members who would like to receive their materials on a thumb drive and bring their PC with them instead of sending you the paper copies, and we will be discussing that with you between now and the next board meeting in January. Regarding our staffing are there any questions regarding our budget? Moving on to the staffing update. On October 29th, Candace Cohen, our Public Information Officer, retired. Due to the hiring freeze, we will not be able to fill her position at this time. Jennifer Samos, our Legislative Director, and the Public Information Office staff, Debbie Nelson and Chris Valine, have stepped up to the plate. It's just amazing to take on this workload of this position. Although we have job announcements out for various vacancies, the freeze only permits transfers within the Department of Consumer Affairs. Thus, it will be very difficult to fill any of our positions. No promotions are allowed, and no new employee hires are permitted. Other agencies that are not frozen may hire and may promote. Thus, we may lose some staff to those agencies. Many employees are covering positions of those that are vacant, and this is especially true with the support staff in the executive office. Renee Threadgill will provide you with an update on the enforcement personnel in her report. An additional information is that the Federation of State Medical Boards is holding its attorney workshop this weekend. We would have sent our 2 attorneys, Anita Miscuri and Mr. Hepler. Unfortunately, they are here, so they're missing that. But luckily, staff from DCA Legal two staff members are there, and they will be reporting back to Ms. Scurry and Mr. Hepler on the activities that were discussed. Luckily, we have additional healthcare attorneys, but as you notice, DCA is also covering for staff attorneys too. So they're in a situation where there are fewer attorneys because they've had some attorneys leave, so we will be working as closely as possible with them to ensure that we have adequate coverage. Once I have a better sense of the furloughs and the free situation, I will let you know via email. We have union agreements out to vote right now, and we have other union agreements that have not been completed that will impact our staff. But I will keep you up to date on what's going on with staff and our vacancies as I find that information out. Are there any questions? Moving on to item C. I'm still planning on convening the subcommittee on strategic planning in early January, so we may discuss the timetable to have a revised strategic plan by the end of 2011. The subcommittee per agenda item 22 is Ms. Yaroslavsky and Dr. Levine. Are there any questions regarding this? In addition, we will be asking the Department of Consumer Affairs to assist us with a individual from their solid division who has expertise in strategic planning as we move through this process. Moving on to item D, page 207. These are the dates and locations for 2011, our board meetings. Note that all are Thursdays and Fridays. We're anticipating no forced furloughs on specific dates. And I do want to draw your attention to the May meeting. It's the first weekend in May because the Federation of State Medical Boards will be meeting the last weekend of April. We had discussed an April meeting instead of May, but our meeting will be in May. The January meeting is planned, I believe, at the Embassy Suites in Burlingame, our regular location. Are there any questions? Please make sure you have those on your calendar. Moving to E, ongoing board evaluations will be discussed with the Strategic Planning Committee and incorporated into that planning process. Our major sunset review will be during 2013. Thus, we will want to anticipate that review in the planning for ongoing evaluations. Are there any questions? Then that concludes my report.
Thank you, Ms. Whitney. Are there any additional questions or comments from any of the members? Is there any public comment on any of these items? Seeing none, we're going to move on to item number 25.
We don't need to. Do you need any time to set up, or are you fine? 5 minutes?
Okay, literally, we have the presenter here for, Mr. Frank is here for item number 25. It's going to take him a couple minutes to set up. So I'm going to ask people, if you don't need to leave the room, don't. If you do need to leave the room, do, and come right back, like in 2 or 3 minutes. Okay, please? Stand up and stretch, walk around the building, walk up and down the stairwell, or stay seated. As soon as I see Dr. Carrion, as soon as I see Ms. Chang, I'm not to see right here. Please. Yes. Oh, I know. Oh, I know. It's just where you stand. Kevin. I need 2 more board members. Eddie and Dr. Carrion. Here's Dr. Carrion. Ms. Threadgill, did you want to say something? Okay, I'd like to get started. If we could all take our seats, please.
Feels like I'm standby or something, I guess. All right. Is that focus?
Okay, we're going to go on to number 25, the board evaluation presentation and discussion. I want to thank Mr. Zeranian and Dr. Salmonson and Mr. Frank for getting, sorry. We're going to have to do this. All right. Yeah. Mr. Zeranian and Dr. Salmonson and Mr. Frank, please provide us with an update on the status of the board evaluation. And Mr. Frank, they're here.
You all have some opening comments first?
Yeah.
Mr. Zeranian, would you like to start, please?
Thank you very much, Madam President. We appreciate the opportunity with my colleague, Dr. Salmonson. We had the opportunity on behalf of the board to review with Mr. Frank as he was going through the process of the evaluation. We have had, at least I have had 2 meetings, the last one being not long ago, perhaps about a month or a month and a half ago, with Dr. Salmonson as well as staff and Mr. Frank. As any good government would do, our board is always interested in efficiencies and ways of serving our mission. Our mission, of course, is public protection, and we always should be looking out for various ways of bringing about better public protection. There is no such thing as 100% of anything. You can only strive for 100%, and that's what we're attempting to do. Therefore, the board commissioned a report from an independent third party, that being Mr. Frank in this case, to look at various ways that the board operated and looked at the efficiencies or inefficiencies of the board to make recommendations to the board in order for the board to look at the policy issues relating to those recommendations and make the recommendations and make the policy decisions with respect to the recommendations. That is the purpose of this dialogue. We appreciate certainly Mr. Frank's being here as well as his hard work putting all this together. Again, what Mr. Frank will present as recommendations have not been seen by the entire board other than in a report and have not been acted on by the board, as this is the forum in public where the board hears these recommendations and ultimately act on those recommendations. Janet, any comments?
No, I would just say you summarized it well, and we've asked Mr. Frank to not just frankly reiterate what's in his report, but also his methodology, and we're looking forward to that.
I know we're limited with time, but I believe Mr. Frank asked for a longer time, but hopefully we can do this in the next 15 minutes or so, if that's...
Thank you.
Thank you. I'll try to keep my comments to about 15 minutes. That's my target. I met with you 3 months ago, and during that briefing, I presented to you a quick summary of findings in areas other than in enforcement. And I handed out to you, I had prepared comments for that presentation. I had copies of those distributed to you because I was not planning today on going through again the recommendations that I summarized for you previously in the areas outside of enforcement. With respect to enforcement, I pointed out to you, and it is on the toward the tail end of those comments, that what we had seen in looking at enforcement was that vertical enforcement had been implemented very differently in different regions of the state, and that variability presented an opportunity to look at best practices and identify ways to implement vertical enforcement more consistently, more uniformly, more effectively, and efficiently throughout the state. And my comments to you today are going to focus on that specific area of recommendations. What prompted us to focus on looking at, as you obviously know, the scope of the study was a broad assessment of the medical board's programs and operations, its fee structure, and so on, organizational management structure. However, if you look at within that broad umbrella, the medical board had specified certain specific things they wanted done as part of this assessment. And this is an extract from, as you can see at the top here, the scope of work. This was in your RFO, request for authors, to do this study. And it included some very specific requirements. You see there, at a minimum, the study is required to address, and D is the efficiency of licensing, enforcement, and cashiering. And it talks to, determine if they are practiced consistently and equitably. Well, if there were issues of enforcement practices not occurring consistently and uniformly throughout the state, then that's clearly within the scope of this assessment. It also asks specifically, item G, the value of services provided to the medical board by agencies outside of the medical board. And the biggest provider of services to the medical board by an agency outside of the medical board is the Attorney General's Office, Health Quality Enforcement Section. It also required looking at policies and procedures that may hinder effectiveness, laws and regulations that may hinder effectiveness, and the elimination or transfer of non-critical functions or resources where it could be redirected to other more critical functions. To perform the assessment, one of the first things we did, because again this involved the fee structure, looked at identifying where you were spending funds for outside services, both contractors and other agencies. We looked at your expenditures by year from 2004 for the last 5 years, 2004-5 to current. And as shown here, one of the major areas of expenditures is the Attorney General's Office, where the expenditures increased from $18 million to almost $12 million during 08-09. We're projected to go to $13 million during the year we were doing the study, or $1 million a month. It went from $8 million to $12 million and on its way to $13 million, which is $1 million a month. And during the study, during the 9-10 year, we actually looked at some invoices, and the Attorney General's Office was billing $1 million a month. So in other areas, the board was not fully expending its budget, but in that area it was. And we also looked again, looking at where your expenditures have increased. The Attorney General's Office accounted for not only the largest single increase in expenditures, but the highest percent, well, it's that second highest percentage increase in expenditures in that 5-year period from 2004-5 to 8-9, $3.6 million a year. So we asked the question, well, we've had this big expenditure increase. Everybody was aware that there was additional staffing authorized for the Attorney General's Office beginning in 2006 to assist with implementation of vertical enforcement. There were also rate increases. So the question became, if we want to look at where there's been this big expenditure and increases and answer the question that's in the RFO, what value are we getting for these services, it sort of prompts the obvious question, what is the additional value that we're getting for this increased expenditures for Attorney General's Office's services? And so the first thing I kind of did to try to answer that, to try to get some information about that question, was I went to the medical board's billing file. They get a billing from the Attorney General's Office every month, and it is essentially each month a stack of paper that looks like this. These are detailed billing records for every matter that the Attorney General's Office works on. Every page basically represents a different matter, either an investigation matter or what they call an administrative matter, which is a prosecution. There's some other minor matters. And the attorneys post their time into the system where it accumulates this information in as discrete elements as quarter-hour increments. So sometimes there's only a quarter hour showing on the sheet, and sometimes there's a whole list of activities showing quarter hour, 1 hour, 2 hour, 3 hour, 4 hour increments. The document, we don't have an electronic File.
Mr. Frank, could you address the board?
Yeah, I'm sorry.
Thank you.
There's no they're not in any particular order, but there are identifiers in them that tell you whether they're administrative matters or prosecutions versus investigations. There's also identifiers that tell you whether it's Northern California, Los Angeles metro area, or other Southern California. So I literally sorted these out on the floor to try to figure out where are we spending all this money. And historically, the medical board has, with the Office of the Services the Attorney General provide, has been in the area of prosecution. So let me put up another slide here for you. There's placards on top of these stacks here, and this is essentially a recap of the information that's on the placards. I sorted these out and said, let me get stacks for each of the three regions, Northern California, LA Metro, and other Southern California, and further subdivided by investigations and prosecutions. And what came to my attention was, if you look at the prosecutions, the stacks are about the same height. And I went through and I tabulated the hours. I did this for 1 month, just for June of 2009. And the total time charges were similar in all three regions. Okay? And all three regions were handling similar numbers of cases. The stack for Northern California is actually a little higher than the other regions. That's the only region that handles almost all out-of-state cases and statements of issues cases. So their stack's a little higher for that reason. But when I got to the investigation stacks, and again, I was just looking at 1 month, the stack for Los Angeles was about 2 times bigger than the stack for the San Diego office, the rest of Southern California, and 3 times bigger than the stack for Northern California, which is San Francisco and Sacramento, and covers all of Northern California. And I thought, that seems odd. Why are the stacks for prosecutions about the same size, but the stack for investigations for LA is so much bigger? And, well, maybe this is 1 month. It's off. So I went and got another month of data. I got August of 2008, the beginning of the year, and I had the same thing. And then I said, well, let me get in the middle of the year. I did January. I got the same thing again. And these are the stacks for just those 3 months. And so if you did for a year, the LA stack would be like up to here, and the Northern California stack would be way down here. And I said, that's really odd. I don't understand that. I said, there's 2 possible explanations. One is they're doing a lot more investigations down there. If they do more investigations, they'll have more time. But all of the data I had shows they do about the same number of investigations as the other regions. You've got 4 offices in each region. You have the same numbers of investigators in each region. They investigate the same number of cases. The same number of cases go to prosecution. You get 900 cases statewide. They get about 350 of them in LA. So I didn't understand this. I couldn't explain it that way. The other explanation is that they're more intensively involved in the investigation. And you're getting some other value from that greater level of attorney involvement in those investigations. I asked the Attorney General's office to provide me with data, a recap of all of their time charges for each of the 3 regions for each of the last several years, from 2006 through 2009, for administrative matters and for investigations.
Mr. Frank, let me ask you a question, because all this number massaging is really irrelevant to the board. You know, we're paying what we're paying. We've already paid what we're paying.
Okay.
So help us out with some conclusions that you're going to get to.
Well, the conclusion is this is a physical manifestation of the variability. When we talk in the report about different models and best practices, this is a physical representation of that difference. The difference being, in this part of the state, the attorneys are much more substantively involved in investigations, and it's costing you millions of dollars for that level of involvement. And in other parts of the state, they're much less involved. and
is
it's
it
costing you a
value-added?
lot less.
So is it value-added important to us?
That's
or
the
value
point,
not?
is what's the difference in performance? Are you getting more
Is
investigations
that better?
done? No.
Are our investigations better with more? Or
Are they getting better? Or is it short? Does it take less
I'm
time?
asking you for some conclusions.
Okay. So I need to tell you about method. One of the key measures that we were looking for in vertical enforcement is that things would take less time. It would take less time to do investigations, less time to do prosecutions, or the total time from referral of a case to investigation to decision by the board or stipulation was less. So I got data on cycle time. And I need to explain to you how I do data on how I determine cycle time.
Sir, was that your mandate to give us that understanding? The cycle time, is that relevant? I mean, I'm just trying to get what part of your report is relevant to us.
I think if you let me give you the cycle time, then I'll tell you the results.
Okay, I just want to keep in mind time.
Let me give you the cycle time. Okay.
In other words, 15 minutes has passed.
This is data I got from the Attorney General's office for their investigations. This is an example of one type of data. And it shows, for matters opened each year, on the left, when those cases were accepted for prosecution. So you open a matter, 64 matters in 06, 64 of them, the investigation was completed and went to prosecution. And then it dribbles out over a period of years, and by 2009, all the matters that were opened in 06 are completed in 09. Okay? And the same for 07, 08, and 09. The way I calculate cycle time, the way it's conventionally done, is you look at completed cases, for example, 270 in 2009, and you look back to when those were started, and you calculate the average time to complete them, which for the medical board is like 18 months, looking backwards from a output. There are other ways you could do it, but they won't give you valid statistics. Okay? And if all I did was rely on this data, I won't get valid statistics, because if I only look at, say, the 211 from 2008 going backwards, it's obviously missing. They do 270 cases every year. I'm only going to deal with 211. I'm missing ones that were started in 2005 going to 2008.
So what did you find out?
So I didn't use HQE's data because it's not complete. You get distorted data. You get partial data. Like if I look at 2009, I can't go the other way and only look at cases that were opened in 2009 because it obviously only includes a small number of cases, 106, that were closed in 09 or 010. Doesn't include those cases that will be closed later.
You don't know what was opened in 06 compared to what was opened in 09.
Right. I can't use that data either. So I used CAV's data. I used medical board's data because with medical board data, I can look at all 270 cases closed every year and look backwards and determine whether there's been an impact on cycle time.
Your findings?
Okay,
conclusion?
findings. I'll give you just two.
Thank you. I'll turn that camera off.
This is number of cases. It says at the top, investigations open and completed by identifier. On the left side there at the top, open by each region. These are only cases handled by the district officers because those are the only ones involved in vertical enforcement. The only ones, for the most part, that HQE is involved with. And you see that, and so you've got for number open, number closed, the difference, and a percent referral. And what you see for LA here is that the percent referred for prosecution compared to the percent open or percent total closed has gone down, whereas in the other regions it's gone up or it's gone up.
So by being more involved, we see that more cases are closed, or by
closed and not being referred for prosecution.
So that's a good thing, isn't it? No. It's a bad thing.
No, that's probably a negative outcome.
I'm trying to get you to tell
right.
us.
Probably a negative outcome. Okay? We're looking for what's the difference. What are you getting for this? What you're getting for having more attorney involvement, if all you looked at was that statistic, is I'm getting a lower percent of cases being referred for prosecution. They-
is that a negative outcome?
I don't understand why that's
Well, you only refer right now about 30, typically, you get 900 cases a year get referred for investigation. This is your historical numbers. About 2/3 typically don't get through the investigation process, aren't proved up to support
They're
a
doing more work in
prosecution.
advance so that you
Right.
put less, it sounds to me like a good number.
So this is saying we're assuming the case mix hasn't changed in just a couple of years. For whatever reason, fewer cases are being referred to prosecution. There could be other factors impacting it, but that's what happens during this period. So the other offices are still maintaining about a 30% referral rate. And LA, where you have a higher level of attorney involvement, your referral rate has gone down. So you're going to have, if that's really a good thing, eventually you'll have none. And you say, I want to do more of that. Eventually you'll have nothing being referred to prosecution. You'll say doctors aren't doing anything bad. Right. So they could be,
I mean,
they could be
your
saying,
statistics can be massaged either
Right.
way. Okay, so
Can you let the interpretation of that data to us at this point? Because I have different viewpoints.
it could be argued that the attorneys have identified cases that don't have merit because they're involved. There's more cases that don't have merit, and so they're making those cases get closed.
okay, so
But if that was the case, you would see some other corroborating statistics, like for those cases being referred for prosecution, there's fewer decline to
Bad
file.
outcomes, right.
Because they can decline to file and they can withdraw, or it can get dismissed later. And we
Conclusions-
don't see any reduction in those other
your
indicators.
conclusions don't show that there were less cases when prosecuted that were appropriate or weren't appropriate, that they didn't end up spending this time in court afterward and then losing, or afterward and winning.
Well, again, we have all the statistics. We're not showing any benefits. I don't see any benefits on the prosecution side. We can go through those statistics, but I didn't see any.
I would rather have
Okay.
some conclusions.
Okay.
You also can look at the time frame to complete investigations. And so this, again, is showing the total completed investigations. So these are either closed or referred for prosecution. There's other tables that give you either if you want to just look at closed or you want to just look at referred for prosecution, but they're the same trends. And what you see is that in all of the regions, the average time to complete the investigations has gone up a lot. Okay? In Northern California, it's gone from 11 months to 13 months. In Los Angeles, from 10 months to 13 months. And in other Southern California, from 9 months to 15 months. They've all gone up. My point is that why, if they're all performing the same, this is my key issue, why are you spending this much more money a year to have the attorneys involved and not achieving whatever your benefits were that you thought you were going to get, effectiveness, efficiency, better, more prosecutions, shorter cycle times, more ISOs? None of those benefits appear to be happening in any of the regions. Why are you, I'm not saying don't do vertical enforcement. I'm not saying it's not a good idea to have the attorneys involved in assisting the investigators doing investigation.
So what do you want the board to do with
why
this
are you
information?
spending this additional funding for?
What are you suggesting that the board do with this information?
Okay. Two recommendations, which I think actually have, there's a consensus about these. Let's try and get this lined up here.
No, don't-
Recommendation number 6.1, redirect some of the funding from the AG's office to more medical consultants in your offices. Okay? And recommendation number 6.2, redirect some of this funding to more medical experts, or to enhancing or augmenting your medical expert pool. I think.
So you're finding that we don't have enough, forget the money, you're finding that we don't have enough medical consultants and we don't have enough medical experts to do the job appropriately. Is that what I'm hearing you say?
And there is a lot of delay associated with the
So the
processing of
delays-
investigations.
So the delays are being caused by a lack of staffing. Is that what I'm hearing you say?
Unavailability of medical consultants is a staffing issue. Unavailability of medical experts is a staffing and a training issue.
So when we submitted the BCP on the medical consultants and we did not receive them, your information would give us backup as to why we really, really needed them. Is that correct?
Right. And I think you'll see the same thing in the monitor's report from 5 years ago, and you'll see it in this report, and you'll see it in the Attorney General's response to this report, all making arguments for boosting and enhancing your medical consultant expert capability.
So this has little effect on the impact of the Attorney General's office with doing the work? Is that what I'm hearing you say?
Pardon me?
This has little effect on the Attorney General's ability to do the job? What really is causing us the issues is the medical consultants' lack thereof and medical experts' lack thereof?
The bulk of the cases that end up being referred for prosecution are quality of care cases. To make a determination on the merits of a quality care case and what information is needed, and to make a disposition decision on those cases is highly dependent on the medical consultant working with the medical expert.
And very little to do with the Attorney General.
And that is a bottleneck in the process.
Okay.
Madam President, if I may, at this point, we thank Mr. Frank for his presentation. But, you know, when you look at, actually, I recommend my colleagues to look to page 218. Unfortunately, you didn't have much time to go through those recommendations. But if you look at page 218 of your packet and go through, there are opportunities, certainly, for this board to look at various policies and efficiencies. I've already said this to both the Attorney General's office and to Mr. Frank. It's obvious. This is not intended to be an indictment of anybody's performance. It's supposed to be an efficiency review, and for us to side by side look at various ways of improving our performance. And if you go to those recommendations, I submit to you that there are certainly some very valid opportunities for this board to look at and continue the dialogue with our Chief of Enforcement as well as our Attorney General's office. And frankly, the Attorney General's office has certainly met with us and attempted certainly to look at various of these recommendations. While Carlos sitting here may not have answers to some of these questions, some of his superiors might. And once we look at these recommendations, and if this board may direct the committee to continue its work through these recommendations with the Attorney General's office, perhaps we can come back to the board with concrete and workable efficiencies, if you will, for us to proceed in our relationship with the Attorney General's office and our own department. That would be our recommendation, if you don't mind, Janet, and then proceed in that fashion, if we might, Madam President.
I think that's an excellent recommendation. If you'd like to put that in the... Do you want a form of motion or just take it under advisement if that's what you'd like to continue?
We're already an established
You're already
entity,
doing it,
so I don't think
that's
that
fine.
there
Let's
needs,
continue.
unless, of course, there is a concern from the board, and then we will proceed as we were doing.
No, I think you all are authorized to carry on, and we look forward to your feedback.
Excellent.
I would like to ask if either if Mr. Ramirez from the Attorney General's office or Ms. Kirchmeier from the Department of Consumer Affairs would like to come forward and have any comments, brief comments, understanding that this is going to be an ongoing, continuing opportunity to be more engaged and come up with efficiencies that work to meet the needs of this board in its totality.
That is correct, and I'll be brief. I'd like, on behalf of HQE and the Office of the Attorney General, I would like to thank Mr. Ben Frank for his report. I look forward to working with the board and with the committee to implement some of the recommendations contained in the report. Thank you.
Thank you. Ms. Kirchmeier?
Yes, also at this time, the department is still reviewing the report, and we have no comment on the specific report, but we will respond to the board once our review has been completed, and we're very willing to meet with the board to have discussions on this item as well.
Thank you very much. So with concurrence of the board, I'd like to delegate the board's evaluation committee, Mr. Zerani and Dr. Salmonson, to work with staff in the Attorney General's office in the development of recommendations we wish to move forward on for our discussion today.
Madam President, I was just asking, Frank, he mentioned that there's a written response from the Attorney General. Is
Yes, yes, it's in your packet, I would think.
where?
No, it's not. But I need to ask for public comment on this as well. So as part of this, before we move on to item number 26, I'm going to ask Ms. Julie Feldmuth, D'Angelo Feldmuth, to please come forward.
Actually, Madam Chair, Julie D'Angelo Feldmuth, Center for Public Interest Law and the former Medical Board Enforcement Monitor. I had some lengthier prepared comments, but in the interest of your time frame and in the interest of moving forward, I'll forego them. I just want to offer my services. In many respects, this report is disappointing to me, but it is also not surprising to me. The shift to vertical enforcement is a culture change. It represents a huge culture change for both the Attorney General's office and the medical board's investigators. And we never said it could be done overnight. I know it hasn't been overnight. It's been 5 years. But it's not surprising to me. And I think, though, that it does, I agree with Mr. Zarunian and Dr. Solomonson, it represents an identification of some very specific areas in which there are problems and an opportunity to move forward toward refining the implementation of vertical enforcement so that it works for physicians and it works for patients. I don't believe anything in this report justifies changing the vertical enforcement statute. I don't believe anything in the report justifies a reversion back to the old, inefficient, disconnect, handoff method of investigating and prosecuting. I encourage you to take it for what it is, move forward, and improve the system. And I offer my assistance to you in that regard in any way I can. Thank you.
Thank you very much. Now moving on to Ms. Simoes. Would you please come forward and provide an update on the status of legislation? You all have your... When do you have what? Well, not yet.
All right, please refer to your legislative packets. As part of the legislative wrap-up, which is item A, I thought it might be helpful to provide a brief overview of the process because we have some new members and because both of the ends of the process are represented in my presentation today, the proposals and the wrap-up from 2010. So I'm just going to briefly provide an overview of the legislative process. The process begins with legislative proposals. To come up with these proposals, I seek input from legal staff, medical board staff on any fixes or additions needed to enhance the board's programs, including important issues raised during the calendar year. These ideas are developed into concepts, which will be presented to you later on in my presentation. And I'll go over once concepts are approved by the board, I'll work with legal, other departments, interested parties to develop the language. And this will include things like meeting with members' offices, meeting with interested parties, discussing them with policy committee, and working with legislative offices to find an author for the bill. In January, I submit the language to the Legislative Counsel's office, and then the bill goes through the introduction process. And so I'll just provide a brief overview. Most of you probably know this about how the legislative process works. So starts going through the legislative process. It's first heard in the policy committee in the House it was introduced, so the Assembly or the Senate. Before it's heard in policy committee, I have to do some background work. I meet with all the staff of that committee, with interested parties. And the more work that's done beforehand, the easier a chance the bill has to pass through that committee. From the policy committee, the bill goes to appropriations committee, and the same process happens for policy committee and appropriations committee. So I meet with interested parties, with policy committee staff, and then it goes to the floor. So this process kind of repeats and goes to the other side of the House. So if a bill was introduced in the Assembly, that process happens in the Assembly, it passes off the floor, then it starts all over again in the Senate. So once it makes it through both sides of the House, it goes to the governor. During this time, I will bring all these bills to the board for positions. Any bill that impacts the board, I provide an analysis, and we'll be going through that in the first part of the section. And once the board takes a position, I attend all policy committee hearings and testify in support or opposition of the bill. I meet with committee staff, the author's office, and interested parties. Also, occasionally, if a bill is controversial or we need extra support, I will sometimes ask board members that have a special interest or something in that subject to testify at the committee in lieu of myself. So we're also at the end of legislative session. So I submit letters to the governor, and they're signed by the board president, and I forward them to all the board members. And so you know what's going to the governor, and so you can also weigh in on that bill with your own separate letter to the governor's office if it's an issue that you think is important. And so now, that being said, let's go ahead and move to agenda item 26A, and that's the bills, the 2010 bills. So if you can turn the Tracker 1 list, the colored list, I'm going to briefly go over what they kind of mean. So the gray bills are the bills that did not make it. They're dead. They're no longer active. The green bills are all the bills that the governor signed. They were chaptered and signed into law. The two pink bills you see on your list are our board-sponsored bills, and they were both signed by the governor and chaptered. And the bills that are impeached were vetoed by the governor. So the first bill on our list is AB 583. AB 583 Hashi was signed into law. It requires physicians to communicate to their patients their license types, their highest level of educational degree, and their board certification. The board took a support position on this bill, and it was signed by the governor. For implementation, board staff proposes to include an article in the newsletter to notify trained board staff and to add this requirement to the cite and fine table via regulations. Does anyone have a question on that bill?
Any questions? Continue, please.
Okay. I'm just going to briefly go over the bills that were vetoed as well. AB 933 would have clarified existing law to require physicians performing utilization review for injured workers to be licensed to California. The board took a support position on this bill. However, it was vetoed by the governor. There's a copy of the governor's veto message in your legislative packets. If no one has a question, I'll just move on to the next bill. AB 1767, this is the Hill bill. It's a board-sponsored bill that requires the board to provide representation to a licensed physician who provides expert reviewer services to the board. And we also added, we actually extended the sunset date on the two members that are appointed by the board to the Health Professions Education Foundation. It's a sponsored bill. It was signed by the governor. For implementation, board staff proposes to include an article in the newsletter to notify trained board staff, to notify Health Professions Education Foundation and work with them, to notify the Attorney General's office, and to inform expert reviewers and provide information during their board training. If there's no questions, I'll move on to the next bill. AB 2386 allows a hospital to enter into an agreement with the Armed Forces of the United States to authorize a physician and surgeon, physician assistant, or a registered nurse to provide medical care in a hospital under specified conditions. This board took a neutral position on this bill, and the governor signed this bill into law. For implementation, board staff proposes to include an article in the newsletter to notify trained board staff, to revise the existing military form and create a new form with added fields. So we have a form that we already use. We can just modify that form to meet the requirements of this bill, and to post a new form on the board's website. And we also have a contact that the author's office gave us from the U.S. military, and we can work with them to provide outreach. Does anyone have any questions? Okay. AB 2566 would have defined outpatient elective cosmetic procedures or treatments, would have prohibited outpatient cosmetic surgery centers from violating the prohibition of the corporate practice of medicine, and would have enhanced penalties associated with violation. The board took a support position on this bill, and the governor did veto it. There's a copy of the veto message in your packets. Does anyone have a question? No? Okay. AB 2699 BASS, this is the bill that exempts healthcare practitioners who are licensed and certified in other states from California licensure. And the purpose, the reason being for it to allow them to provide voluntary healthcare services to uninsured and underinsured Californians on a short-term basis. This bill, since our last board meeting, the bill was amended to apply to all Healing Arts licensees and limit the sponsored events to 10 days, although there's no limit on the number of events that can take place in a year. The bill now also requires practitioners to provide a copy of his or her license in each state where they are licensed. The license must be in good standing, and each board must prescribe a form for the individual to fill out and set a fee and regulations for processing the request for authorization to practice without a license. Each board must also specify the appropriate education, experience, and regulations. The bill also includes a termination process and will sunset January 1st, 2014. This bill does have a fiscal impact on the board. For implementation, and the governor signed this bill, the board had an opposed position. For implementation, the board has submitted a legislative BCP to DCA for the half a position that's needed to accomplish the extra workload in the bill. And we have not heard back from DCA if that BCP has been approved or not. In addition to including a newsletter article notifying trained board staff resources to manage the program will need to be identified. We are also in the process of working with DCA. I had a meeting with DCA last month, and other boards and bureaus also attended, and it was to talk about the implementation of the bill. And in the meeting, DCA committed to drafting model regulations. So all the boards and bureaus can use this as a template for their regulations. Each board and bureau will have to develop their own regulations, but DCA will start, and the purpose is to have a more uniform way of implementing the bill.
Right. For instance, there is a need for a definition of community-based organizations, and it would be better if that definition were the same across all boards. At least we give the boards the resources to have some sort of a definition available to them that they could all use. So the plan, I believe, is for the legislative and regulatory unit to be developing those regulations, and our office will be reviewing them.
And DCA also in that meeting, DCA committed to being the responsible party to approve the sponsoring entities. So basically, they would approve the sponsoring entities, and all the boards and bureaus could use those entities that DCA has approved. And so once we get those model regulations from DCA, we'll work on, reviewing them and coming up, filling in the blanks. So we'll have to determine the fees, the appropriate education experience in our regulations. Does anyone have a question?
No.
If the regulations are drafted in the near future, the language may be discussed at the next board meeting.
Well, since we have the regulation for California licensed physicians to have to post that they're under the supervision, if you will, of the medical board, what sort of information is being provided the people receiving care so that if they do have a problem with their quality of care, they know that they should be telling the board, if in fact they should be telling the board?
Well, that's also something we might be able to specify in regulations if we want that kind of specifics required out of them. It gives us I believe that we have the authority to specify that in regulations if you want to. Is that right, Anita?
I feel there would be otherwise a double standard that if somebody goes to a California underserved clinic situation, they have the right to complain about quality of care, but if you go to an out-of-state physician who's in California, they don't know that they've got an option to report any issues they might have.
And I think that's a good idea and something that we could require in regulations.
Along with that, the ability to maintain records, a modified version of follow-up care recommendations, and I would venture to say that since DCA is the lead on overall standard of practice here, that maybe in addition to those doctors being regulated by whatever entity they might be regulated to, that the Department of Consumer Affairs, along with the medical board, should get direct notification of any problems so that they'll be aware of them as well.
Okay, and I can work with DCA when they pass out the first draft of those regulations.
So the issue is all of the standard of care expectations that are expected by a California physician need to be addressed.
Okay.
And where those complaints will be returned to need to be addressed.
Okay.
And the other issue is, since, again, we heard yesterday how meticulous the clinics here were in terms of having malpractice coverage, one would want to know what the liability coverage is being provided, because
I think the sponsoring entity provides that malpractice insurance.
But I think that would be important that we know, because again, if that's part of patient protection for people getting their care from a California physician, they need that same option.
Okay, thank you.
Thank you. Any other comments on that one? Specifically, continue, please.
Okay, the next bill is SB 294. This is a bill that changes the sunset review date on various DCA boards and bureaus, including the Medical Board of California. The bill changes the sunset date from the Medical Board from 2013 to 2014. The board did not take a position on this bill. One wasn't really needed, and the governor did sign the bill. So for implementation, board staff proposes to include an article in the newsletter, notify board staff, and prepare for performing a sunset evaluation report in late 2012 in anticipation of legislation in 2013. Okay, the next bill, SB 700, Grady McLeod, adds a definition of peer review, adds that the peer review minutes or reports may be obtained by the board requires the board to post a fact sheet on the internet that explains and provides information on 805 reporting. The board took a support position on this bill, and it was signed by the governor. For implementation, board staff proposes to include an article in the newsletter, notify trained board staff, and develop and post the fact sheet and post it on our internet site by 1/1/10. Any questions? Okay. SB 1069 authorizes physician assistants to perform physical examinations and order durable medical equipment. In earlier versions of the bill, it authorized PAs to certify disability for the purpose of unemployment insurance eligibility, but that provision was taken out. The board took a support position on this bill, and it was signed by the governor. And for implementation, board staff proposes to include an article in the newsletter. The next bill, and this was discussed a little bit previously when talking about uniform standards, SB 1172 codifies many of the uniform standards established by the Substance Abuse Coordination Committee. The bill requires all healing arts boards under DCA, including the medical board, to order a licensee to cease practice if the licensee tests positive for any substance that is prohibited under the terms of their probation or diversion program. This bill also allows healing arts boards to adopt regulations authorizing the board to order a license to cease practice for major violations or in order to undergo a clinical diagnostic evaluation. The board took a support position on this bill, and it was signed by the governor. For implementation, board staff proposes to include an article in the newsletter to notify trained board staff, and since the regulations were held, and to include that information in the regulations. We did have that we were going to update them, but since they got held, we can just hopefully include it in there. Any questions?
No.
Okay. SB 1410, Cedillo. This is the bill that would have deleted the limitation that an applicant for licensure may only make 4 attempts to obtain a passing score on Step 3 of the USMLE. It would have also required the board to adopt a resolution at a public meeting every time it adopted a passing score, and would have required the passing score to be a numerical score, not a percentage. The board took an opposed position on this bill, and it was vetoed by the governor. And there's a copy of the governor's veto message in your packets. And lastly, SB 1489 is the BMP omnibus bill, where the board sponsored technical fixes in the omnibus bill. The bill deletes and corrects obsolete references related to the board's division of licensing and exams, reinstates postgraduate training requirement for licensure, and along with some other midwifery reporting requirements. The bill obviously we took a support position, and it was signed by the governor. For implementation, board staff proposes to include an article in the newsletter and notify trained board staff. This concludes my presentation for A. Does anyone have any further questions? Okay, let's move on to B, which is medical board staff proposals. Okay, so I'm going to go over the staff proposals that staff has identified for 2011. So the first one has to do with, would require physicians to cooperate, attend physician conferences with the board, and to consider noncompliance and professional contact. This is similar with the requirements of the State Bar of California. It would require physicians to cooperate, and will the impact will be it will expedite the closure of some of our cases. It will no longer require the medical board to subpoena physicians who do not cooperate, which currently is adding time to our cases. Staff recommends that a motion be made to authorize staff go forward with this proposal and seek legislation.
So I would entertain a motion to that
So
effect.
moved.
Second? Any public comment on that? Any members' comment on that?
Yeah, I have a question, actually.
Oh, yes, sir?
What exactly does this mean, to attend conferences?
Well, I believe that there's some discipline type conferences right now that they're not willingly cooperating with us, and so because of that, it's adding time because we have to subpoena to require them to cooperate.
Right.
And so it's just basically adding time because, and eventually we'll have to, they will be subpoenaed to cooperate with us, but if we put it in law, it would make it unprofessional conduct if they didn't. So we could skip that step of subpoenaing them.
They have to come to an interview.
Yeah, I guess the question about the conference, it's just like a vague term.
We're not going to mandate doctors go to conferences.
Yeah, trust me. No, so you mean like interviews, investigative processes, meetings?
And when we develop the language, we'll make that clear.
Yeah, okay. I'm an English minor, so it's...
It sounds like management thing rather than...
Ms. Kirchmeier?
I just had one comment on this, and I have to turn to the attorneys on this as well, but other DCA boards right now, this was one of the proposals that was going forward in the regulations that boards were putting into their regulations, that it would be unprofessional conduct for the individuals not to basically comply with the board. So I'm just going to throw that out there. It is in the regulations.
So might you consider changing the term conference to interview? To clarify?
I think that's fine. I mean, I'd have to double check. That's what's
So would you please check on that?
Yes,
Thank you.
I would make one point, that this is not really a solution to the issue of whether or not it doesn't remove the requirement for subpoena if in fact you still want the records. It just gives you another little thing to throw in the accusation should they not.
Thank you. Continue, please.
Okay, then, excuse me. The next proposal is authorize staff to seek legislation to automatically temporarily suspend a physician and surgeon certificate when a physician is incarcerated after a misdemeanor conviction. Right now, we have this authority for felony convictions, and we would like to have the same authority for misdemeanor, because the purpose is we don't want a physician that's incarcerated to have their license while during that period of incarceration.
We have a motion, and I apologize. I was going to do all three, but we have to do it as they come. So let's stop for a moment, Mrs. Mose, please. And I would call for a vote to approve the first one. And I have a motion, and I have a second, and I would ask for an aye vote. All those in favor?
Aye.
Any opposed? Thank you. My apologies.
Okay, so the next one that has to do with the incarcerated physicians. We've had instances where physicians have been incarcerated, for misdemeanor violations and have been incarcerated and have had their medical license, and that's obviously an issue. So we would like to have the authority to also temporarily suspend when they have a misdemeanor as well.
So need a motion to that effect, please?
Second.
Okay, discussion from the members? Any public discussion? All those in favor of the motion as it stands, vote aye, say aye, please. Aye. Any opposed? Seeing none, that carries. Continue, please.
Thank you. And then omnibus, we always have proposed technical fixes that we include in omnibus bills. There's been some identified in Midwifery Advisory Council that may need to be included. There's some cleanup language that needs to be included for licensing. And so staff is asking for a motion to be made to approve adding technical language in the BMP omnibus bill. There may be some more little technical kind of things that come up during the year, but there's pretty strict requirements on omnibus bill. It can't be controversial. If it is, it's not a candidate for an omnibus bill, and we would, run the technical fixes. We'd work with legal on that language.
So may I have a motion for approval, please?
So moved.
Second? Any public comment on that one? Any other additional comments from members? No, seeing none. All those in favor, please say aye. Any opposed? Okay, that carries. Thank you very much.
And then we just have a couple of proposals that actually aren't from staff. They're from the board evaluation report. They're recommendations that were made in that report that require statutory changes. And so one of those, the first one, is number one, is to authorize staff to seek legislation to amend the statutes governing vertical enforcement to clarify the medical board's sole authority to determine whether to continue an investigation. Per this report, this recommendation will promote efficiency in the enforcement program by clarifying the medical board and AG's office roles. Legislative clarification most likely won't make a practical difference. Staff recommends instead revising the VE manual to allow the medical board and the AG to work together to implement VE instead of actually changing statute.
Second? Any public comment? That was a motion. Okay, so some public comment?
Thank you, Madam Chair. Julie D'Angelo, Falmouth from the Center for Public Interest Law. I would submit that any recommendation for changes to the vertical enforcement statutes at this point are premature until your subcommittee has had a chance to fully ingest this report and the full board has had a chance to ingest the report. And I understand that's a work in progress. So I think that motions to amend the VE statutes may be premature.
So would the maker of...
The motion actually was to affirm that we would not.
Right. The motion was different.
I'm sorry.
The staff recommendation.
Rely on the menu.
Okay, is there any other public comment on... Okay, all those in favor of the motion as stated, please say aye.
Aye.
Any opposed? Thank you.
Okay. And the next one, per the board evaluation report, authorize staff to seek legislation to amend current law to no longer require medical board investigators and HQES attorneys to be permanently co-located. The pro would be co-location is found to be impractical. Repealing existing law would legislatively mirror current practice. But the con is co-location is actually not in existence in current practice, so legislation really is not needed. But an option would be to include this language in an omnibus bill if it's non-controversial. So I guess the staff recommendation would be included in the omnibus bill only if it's non-controversial, and otherwise we just wouldn't go forward.
I guess my question, Madam President, whether or not this is even needed. It sounds like it may be redundant.
Right. So we don't really need to.
2 and 3.
So I would assume we don't need to do anything with that one.
Yeah, we don't believe that it's actually needed, but unless if the board wants to go forward, the option would be to include it in the omnibus bill.
I think that's fine. Thank you.
Okay. Okay, the last one is, per the board evaluation report, authorize staff to seek legislation to amend current law to no longer require the medical board to invest in the computer tracking system CAS to make it more compatible with HQES's pro-law system. Repealing this requirement would no longer require the medical board to invest funds into CAS. This change is actually not needed because with the approval of DCA's Breeze computer system, took care of this change. It's no longer needed. We're working on a new computer system, so staff recommends that we not go forward with this proposal.
Okay, thank you. So we'll go along with staff recommendation from that one.
Are there any other proposals that members want to bring to?
Any other? No, thank you.
Are we going to revisit the whole issue about, I see the governor vetoed the medical spa, and the message is kind of curious in there. But I think we need some kind of placeholder because we need to address it legislatively, and maybe we need to change the approach that was taken because it sounded like we wanted to push this above everybody else in terms of quality issues, and that wasn't the case. So I would think that we need to rework that and get that on the agenda.
I think we need to wait to hear the recommendations of that committee when they're finished with their work.
Maybe we have a placeholder, though, so that we know that we're going to move on something in January.
What are the methods for communicating our interest in pursuing this?
Well, I can work with interested parties and work with committee staff once the recommendations come out. Usually we can, even if it's later in the process, we can find a vehicle, find a bill that maybe we can, like we did for HPEF, we had another sponsor bill where we put that language into that bill, and so we had like a vehicle because we were going to have some other sponsored bills.
I think this is the third iteration of that particular bill.
The other point to consider is there's a new administration that that's coming on, so it might be a different story this year. But we can introduce placeholder kind of bills that just change one little and to just a tiny technical change that means nothing, that just holds. It's basically a placeholder kind of bill, spot bill.
If I may, because of the sponsors of the bill and their continuing interest in this particular legislation, maybe we'll just direct staff to work with them and have it out there if we could incorporate something into it if we come to any conclusions.
Great. And can I ask that we also examine whether or not we can do some of this by regulation, see within the scope of the medical board if we can specifically address, because this is going to be a kind of a burgeoning area in many fields of medicine about the supervision and application of mid-level practitioners, and that perhaps is the way we can pull it in instead of singling out just cosmetic or medical spas.
We'll make sure to just address that specifically at the next meeting.
Thank you. Thank you. Moving on to
26C.
26C, I'm sorry.
Other legislation. The legislature is actually in recess right now, and it's not going to be in session until December. There's only one proposal that's been brought to my attention at this time, and I'm going to briefly go over it. This proposal is being jointly sponsored by the Radiology Practitioner Assistant Society and the American Society of Radiologic Technologists, which is a national society that supports radiology technologists in different modalities. The legislative proposal will create the Radiologist Assistant Committee of the Medical Board, similar to the Physician Assistant Committee. The Radiologist Assistant Committee will license radiologist assistants, and it would be similar to Physician Assistant scheme. The radiologist assistant licensing category will actually include 2 current mid-level radiology technician classifications, the radiologist assistant and the radiology practitioner assistant, which are both trained advanced technologists with separate educational background. Both technicians provide radiology services by assisting the radiologist with less invasive procedures, allowing the radiologist to focus on less routine patients and studies. This bill will help to recognize these individuals so they may continue to provide care in California. I'm just bringing this to your attention. The bill hasn't been introduced yet. The legislature's not in session. But I believe there's some members of the public that want to speak to the board on this
Right,
item.
I have 4 requests to speak. The first one being Bryce Daugherty. Please come forward. So, Dr. Thomas, are you coming up?
Yeah, we're...
Okay. I'm not sure of how the 4 people are, I don't know if they're...
There'll be 3 of us, but it'll be myself, Sal Martino, and Dr. Thomas. And then Marceline Compton after that.
Okay, so those 3, please.
Madam President, members of the board, Bryce Doherty here on behalf of ASRT. In the interest of time, we'll be extremely brief. I think Jennifer went over really well, kind of at 100,000 foot level, what we're attempting to do. I want to leave the board with 2 comments generally. Number 1 is we wanted to come to the board early to let you know that this proposal is coming. Number 1, we definitely will be sponsoring legislation in the upcoming session. And I mention that because some members of the board and staff and some others are aware of this issue. This issue's been around since 2003. There's been sponsored legislation to try and get at this in one way or another since 2003. I know there has been some mixed feelings about the proposal, particularly from the practitioner side. I just wanted to let the board know that we are all in strong support of the proposal that's going to be moving forward. I've shared a draft with Ms. Simoes and staff. And once we get something back from Legislative Council and an author and a bill number, I will certainly keep staff in the medical board aware of that. The other thing I wanted to let you know is I understand, from my grandfather told me a story that when the oats get low in the trough, the horses start nipping at each other. I understand we're in a situation where we have diminishing resources. I understand that the medical board is extremely stressed with the resources, sharing of staff needs, and what have you. Our goal and our intent with this legislation is to make it self-sustaining. So we want it to be 100% fee-supported in the method and manner by which you think it would be best to do that. We would welcome your technical support and any issues and guidance you could provide us. So with that, I just want to turn it over to Sal Martino, who is the Chief Executive Officer of ASRT. Thank you.
Thank you. Mr. Martino?
Thank you for the opportunity to speak today. I'm here to discuss the development of the radiologist assistant and the profession's efforts to have radiologist extenders recognized by the state of California. My name is Sal Martino. I'm the Chief Executive Officer of the American Society of Radiologic Technologists, a national organization representing more than 138,000 professionals who perform medical imaging and radiation therapy. ASRT's membership includes nearly 10,000 California radiologic technologists. In the mid-1990s, ASRT held a consensus conference with educators in the profession to plan the profession's course for the future. In response to projected increase in the numbers of imaging procedures and examinations, decreasing number of radiologists entering the field, and a desire to create a career ladder for clinically attuned radiologic technologists, the ASRT, the American College of Radiology, and the American Registry of Radiologic Technologists, and others collaborated in the development of a radiologist extender, a radiologic technologist with additional formal degree-based education who would also be clinically educated in one-on-one preceptor model by a radiologist to perform a specific set of interventional and imaging procedures. This radiologist extender, known as the radiologist assistant or the radiologist practitioner assistant, is now an accepted member of the radiology team. There currently exists around 500 individuals practicing nationally, with 28 states, including Florida, New York, and Illinois, licensing, regulating, or recognizing the radiologist extenders. We hope that California becomes the 29th state. There are currently 11 radiologist assistant educational programs, which all culminate in the award of a baccalaureate or master's degree, and certification boards whose radiologist extender examinations have been accredited by the National Commission for Certifying Agencies, one of which certifies more than 300,000 medical imaging and radiation therapy technical professionals and has been in existence since 1922. Loma Linda University established the first radiologist assistant educational program in California, and a number of the graduates from this program are here with me today. And many radiologist extenders in California are graduates of Weber State University in Ogden, Utah, the home of the first radiologist extender educational program. A radiologist assistant, which is the title we are seeking licensure for in California, is specifically educated to work in a radiology department or for radiology practices. In these settings, radiologist assistants are able to use their skills as radiologic technology experts and their additional clinical skills gained in the educational program to improve the efficiency of radiology departments and radiologist practices in providing patient care and help radiologists meet the sometimes urgent need for interventional procedures. Radiologist assistants cannot interpret imaging examinations, diagnose patients, or prescribe medications or courses of treatment, nor are they a replacement practitioner for a physician. They exist to supplement the radiologist practice and to assist with radiologic patient care management. Thank you for making time to discuss the role of the radiologist extender in our efforts to license radiologist assistants in California. I'd be glad to answer any questions if you have any.
Thank you. Dr. Thomas, do you have some?
Yes, thank you. My name is Roger Thomas. I'm a radiologist in full-time practice in Orange County, and I'm the past president of the California Radiology Society. I'm here to lend my support to the licensure of the RA program and to seek the medical board's support of that. We have successful nurse practitioner, PA programs throughout the state because of population needs, increasing medical needs. But we don't have anything for radiology per se, and the RA program was a specifically designed program for that need. It was set up with a combination of the American Society of Röntgen Technologists, which Mr. Marino is president of, and with the American College of Radiology, which I'm on the board of delegates of. And it's a program in which the education, the curriculum, the requirements, the certification, all have the input of radiologists, and we're very proud of the program and what's been created. As far as the medical board is concerned in the state of California, you are concerned about the safety of the population and the care that they receive. As somebody who has a RA person working with me, quite honestly, now that they're fully trained, I don't know how I would be able to work without them. They're absolutely a superb addition to the radiology practice, and I fully support the implementation of that and seek the medical board's support in that regard.
Thank you very much for your comments. Nobody has any comments, but thank you. I'd like to call up Marceline Compton to speak.
Thank you, Madam President. Also, thank you to all the board members. I know that y'all's time is very valuable, so thank you for allowing me to get up and speak. I'm Marceline Compton. I am currently serving as president of the Radiology Practitioners Assistant Society. And together we have worked with the ASRT to come up with what I feel is a true compromise between the two working professionals in the past and coming together in the future and uniting us under one name to help the healthcare in California and first and foremost to serve the patients in California and continue the care. Again, as representing many of the RPAs that work here in California, I would like to ask for the board's support too so that we can go on ahead and continue to do this and have a state recognition and continue to not only grow the health care in California, but to allow that access to all the patients. So we're just seeking your support as well too.
Well, thank you very much. This board's not going to be taking any action right now until there is really a bill in front of us, but I want to thank those public speakers that have come to engender our support. We'll wait and see, but thank you for your time.
Thank you.
Anything more, Ms. Moss? Okay, we're going to just do a little bit more before we take a break, a half-hour break for lunch. So we're going to move on to item number 27. Sorry. Are there any questions regarding the regulatory matrix? And if not, we're going to move on to item number 28. And I would ask Dr. Israelian and Mr. Warden to speak with us.
Great, thank you. Dr. Lowe is not here. Dr. Lowe is actually the head of the Special Task Force on International Medical School Recognition. In the spirit of cost effectiveness, we've increased the task force by 100% without any extra cost. So now I'm part of the task force too. Basically, if you could turn your page 224, agenda item 28, as of November 1st, the board had 3 medical consultants. The board is looking for 2 to 4 more part-time consultants to basically renew new applications. There's currently a hiring freeze, so no additional new consultants have been hired, and we cannot extend current appointments at this time. So are there any questions from members at this point?
Any questions?
I just have one comment, and just it's an information point. The ECFMG has a new goal. They're going to certify international medical schools by the year 2020, I think. So I thought maybe some of the work that we have to do, maybe we can work with them to some extent, because they have to do it.
Ms. Chang, just so you know, when we got that notification, we immediately contacted them and have offered our assistance, support, anything we can do to help them understand what we do here in California so we can pass along that knowledge.
Okay, and if you want to, I can get them to come here and do a presentation for us, if you're interested in it.
Ms. Rowling, continue.
Are there any public comments? I didn't receive anything either. Okay, so in that case, Mr. Warden's going to present his report. Please, can you update us on the status of the medical schools that were being reviewed?
Yes. Okay, well, I'm going to start with the University of Silesia. They're in the process of being reviewed. We sent a reminder letter for them to send us additional information, and since this was printed, they have responded that the additional information is on its way for us to review. The Medical University of Warsaw has also been sent a letter for reminder, and they have told us that they are working on it as well. Just a second.
Now, Mr. Wharton, let me just ask you, on you're completing 28B. You're speaking on that, correct now?
No, I haven't got to 28.
No.
28, you're just make sure where you are, because I've got to fit in public comment in between, so that's what I'm trying to do. Continue, sorry.
All right. As far as the Universidad of Iberoamericana is, staff has transmitted information to the medical consultant on that particular school. Let's see. The University of Ras Bahamas is scheduled for review later in item 29. And the University of Tecnon has been asked for additional information, and they've been advised that additional information is actually in our office today. So I'll be proceeding on, well, I'm done with the rest of those schools.
A. Okay, so we're finished with A. I'm going to suggest to continue with B before I call on Mr. Oh, good. I didn't see what it says. It just says 28. Okay, good. So wait. So continue with B, please.
Okay. For the American University of Antigua, the staff has had the medical consultant review the information that was provided just prior to the July board meeting. The medical consultant has requested additional information regarding that, to clarify that information. That request was sent out on October 14th. And in addition to that, staff has been working on the preliminary request for out-of-country, out-of-state travel for the site visit that was authorized once the medical consultant deems the proper locations and the time for that. The tentative request is to get the governor's office notice that we're going to need that travel in the future. It's been drafted, it's at my level for review, and hopefully that will be going forward a little bit later this month, around the week of the 17th of November.
Have you in fact gotten the information requested from the October 14th request for additional information?
Not yet.
So that's not been coming, that's not forthcoming yet. Okay, so continue.
Okay, and that's
Wait,
all.
that's for B.
That's for B.
Let me know.
think he's done with B.
I am done with B now.
Okay, fine with B. So we have public comment
Well, we
on B.
have member comments first, right?
Yes.
I guess maybe it wasn't the school, but like you wouldn't probably make the site visit if they haven't given you the written material. Yeah, perfect.
The site visit process is very lengthy to get the approval from the governor's office. So.
But I mean, if they're not doing their part on that written part, you wouldn't go there until you got everything?
Correct.
Okay, perfect.
And we did review the materials that were submitted. We've asked additional questions, but that doesn't stop us from moving forward with preparing all of the documents that need to be done in order to ask for an out-of-country trip. So we're doing it at the same time in assumption that we're going to receive all of those materials and there's no issue regarding the out-of-country trip.
We need to keep it going in the loop so we don't get caught up with a time constraint. So I have public comment, please, from you, Mr. Sclafani.
Good afternoon.
Remember my 3-minute rule. You've heard it before.
We're very distressed. When we were here in July, the board ordered a site visit. It's a quarter of a year later. Hasn't moved one bit. The responses to the October 14th questions were submitted. You have them. The questions that were asked were only 2. They had nothing to do with the material that was submitted before, and frankly, they were ridiculous. One suggestion was that we delay the site visits for a year and a half until the new curriculum that we told you that we were implementing, the revised curriculum, could be implemented, because we said that it would be implemented in August or September of 2011. And the proposal in this document was that that the site visits be delayed for 3 months after that, so that the site team could view the curriculum. You can't view a curriculum in a site visit. It's ridiculous. The other questions that were asked were questions about the KMCIC program that were laid to rest at the last board meeting. It's a separate program. It isn't the program for which we're seeking recognition. That issue was resolved last time. We were told over the last 3 months various things by the board's staff as to why this matter wasn't moving forward. We were told that the board was waiting, that they were waiting for the state budget. State budget has nothing to do with whether or not site visits happen. We pay. And it wasn't part of the board's resolution that the site visit that they authorized in July be stayed until the November meeting of the legislature could agree on a budget. This process is just getting dragged on and dragged on. We know why, and I think you know why. This process...
There's no discussion here. This is his opportunity to have a discussion without, a statement. There's no discussion. This is not a conversation.
Right. I'll answer that question. The reason why is because we made it clear, we were told all along that after the board files the papers to get the governor's approval for the site visit, in the past it's taken over a year to get that permission. And our consultants said that they could short-circuit that and have it right away because they had people in the governor's office that were anxious to see this process move forward. But the governor isn't going to stay in office very long. So the idea here is to see how long you can stall this process out so that it'll take another year and a half to get approval for something that the board knows should be done. The document that was part of your agenda identifies when work began to request the governor's consent. October, 3 months after the board directed that site visits happen. When we left on July 30th, at the last quarterly meeting, the only issue that remained open was whether or not the materials that we already had submitted, some of which the consultant had already reviewed because he commented on them at the last meeting, would be sufficient to eliminate the need for a site visit. I want to remind this board that only 20 schools out of the 1,300 schools on your list were the subject of any gathering of any information or any self-assessment reports at all. I'm sorry. Self-assessment reports were only requested for some of those schools. The board sua sponte denied certain other schools. So of the 20 schools that they gathered information on at all, the only schools that have ever been the subject of site visits are Caribbean schools that serve American population. The 9 European schools that who the board approved, they did so without a site visit. The Cuban school was approved without a site visit. In our case, we were told in advance that a site visit was going to be required of our school before they looked at any of our documents.
You're going to need to wrap this up, please.
Sorry?
You're going to need to wrap it up. Your time is just about up.
I could go on for
No, I know. Thank you.
quite a distance with the material that we found about the discrimination of this board with respect to Caribbean medical schools and our school in particular. You know, and the reason for it is that we service the American population, not foreign population, and it's the only reason for it.
Okay, thank you very much for your comments.
Any more public comment?
Any other public comment?
So if you move to agenda item 28C, Mr. Warden's going to talk about 3 other issues. We have some agenda items. The document CCR 1314.1 lays the foundation for the periodic review process. There's a staff memorandum to board members, which is a recommended action Mr. Warden's going to talk about. And then there's the documented self-assessment report.
Okay, staff's recommending that the board should delegate the duties to the Task Force on International Medical Schools with a final recommendation on the reevaluations coming to the full board. Currently, we have on last page of the additional handout for agenda item C, the schools that have been approved by the board that are due and their due dates for being reevaluated. There are 3 schools who should be considered at the top of the list, which is American University, the Caribbean, Ross University, and St. George's University. Those schools were approved prior to the current regulation requiring reevaluations on a 7-year cycle. So they have been approved the longest, and they are technically due for review this December. However, with staffing, and we will not be able to accomplish that, so we'll have to come up with a new schedule, and so the dates are there. We also need to evaluate the self-assessment report to see if we want to have a separate self-assessment report for reevaluations versus initial evaluations, and if that's an option or not. So, and you also need to consider the cost to the board for the reevaluations and the difficulty in obtaining out-of-state, out-of-country travel for the site visits during this process, and whether or not you would what the criteria are for determining the reevaluations. So, the background for the law that requires that, so the regulation, is 1314.1, Section F, and that's also included in the handout. So that concludes my report.
And your recommendation, sir?
And my recommendation is to delegate to the task force for us to work on these issues for the revised site visit schedule, the self-assessment report, and let them delegate that to them so that they can report to the board with the findings.
Thank you very much. Dr. Zerlin?
So, I mean, do we need a motion for that?
No.
Okay, so unless anyone objects, we're just going to delegate these responsibilities to the task force then.
Thank you.
Thank you.
So if there's no additional questions or comments from the members, and is there any other additional comments? Wait. From the public, why don't you wait until Dr. Service has finished his report? Okay, I think that'd be fair. Okay? So I'm going to I see none, right? So we're going to move on to agenda item number 29. And Dr. Service, I would ask that you come forward and join Mr. Warden, please.
Okay. Okay, I'd like to introduce Dr. Service to you and give you a little background. Dr. Mark Service is an Associate Dean of Curriculum and Competency at the Development at the University of California Davis School of Medicine. He's also a professor of clinical psychiatry and vice chair of education in the UC Davis Department of Psychiatry and Behavioral Sciences. Dr. Service graduated from Yale University School of Medicine, completed his residency at New York Hospital Cornell Medical Center, and joined UC Davis in general psychiatry in 1989. During the past, Dr. Service is a past president of the AADPRT, the American Association of Directors of Psychiatry Residency Training, and is a chair of the USMLE Step 2 Test Committee in Psychiatry for the National Board of Medical Examiners. Dr. Service is also a member of the Residency Review Committee in Psychiatry for ACGME.
Thank you.
I'll let Dr. Service present his report.
Thank you, Kurt, and good afternoon. My report, and I assume you have copies of it. Good. I'll be brief then. It's based on the self-assessment report from the Ross University Branch Campus in Freeport, Bahamas, as well as clarifying materials that they provided to us from staff questions, and then subsequent questions which I had after reviewing those materials. And then we also did receive unsolicited documents and materials from a Ross University student, which I did review as well. So this review is unique, I think, in a couple of respects. One is that this is a branch campus, and so it is only a component of a previously recognized an approved school, the Ross University campus in Dominica. And it is the third and fourth semester that this branch campus teaches of that recognized curriculum. And they teach it again in Freeport, Bahamas, a distant site from the Dominica campus. And so this is a 30-week part of the overall four-year curriculum, a relatively small piece, which represents maybe a fifth of the overall medical school curriculum for these students. The review is also unique, I think, in that the branch campus utilizes a great deal of distance learning. Distance learning that is both the spatial, meaning faculty and students are not necessarily in the same place, and temporal, that it occurs at different times from the faculty and students may be operating on different time frames. And the distance learning incorporates a great deal of self-study on the part of the students at the branch campus. But there are, as well, faculty and student interactions around small group teaching. Approximately every week they do 2 hours of problem-based learning, small group teaching, 2 to 3 hours of simulation, a couple of hours of team-based learning, or TBL. And those do have faculty and student interaction. And so in reviewing the materials that they provided and the clarifying materials that were acquired from the staff comments, I had 3 additional things that I requested from them that I thought needed clarification. One was how they were assessing the students that were involved in this very self-directed learning activity, how they monitored their progress, how they monitored attendance and involvement in this curriculum, as well as asked for specific descriptions of how they taught their problem-based learning small groups and their team-based learning small groups. And finally, how they ensured that their faculty received adequate training to do this kind of teaching in the curriculum. And they did provide, I thought, very good documentation that met my level of concern around these issues, and I think meet the standards that the LCME has outlined for distance learning as well. So based on these reviews, I was comfortable with recommending that this branch campus program be recognized by the board. We did receive, as I mentioned, unsolicited comments from a student, but not a student, as far as I could tell, that actually was part of the Freeport campus. It appeared to be a student who was on the Dominica campus. They did raise a number of concerns about the overall curriculum there. And I think it's prudent that the site the Dominica campus site is up for re-review. And because this approval really is anchored in the board's recognition of that base program, I think it would be important to take a very good look at that program, and I think recommending a site review for that program makes a lot of sense. But I am happy to answer questions.
So I would entertain questions from the members of the board. Thank you.
So what subject matter were those weeks encompassing?
Microbiology, pathology and immunology, pharmacology, those are all 30-week courses within those 30 weeks of teaching at the Freeport campus. And then 2 15-week courses, one that's an introduction to clinical medicine and one in behavioral science.
And is there this type of distance learning in any other, say, U.S. medical school or the European schools? I mean, is this distance learning the kind of state-of-the-art nowadays?
Well, it's increasingly utilized in U.S. medical schools and European schools, and the methodology that they use, I believe, meets the standards that the LCME has set.
Okay.
So I have 2 questions. So our council also wisely brought up, so are you recommending approval retroactively to 2009 when the school was, okay.
I would.
Okay. And the second question I have is it possible for you to share the concerns of that student? I mean, if it's relevant.
Well, it's a very lengthy set of documents, and it includes videos, and it's a bit rambling, but it raises a number of interesting concerns. And again, as I went through all of it, it related, I thought, more to the Dominica campus than to the Freeport campus. So I didn't feel it bore much relevance to my review. But the kinds of issues that were raised, there was a general allegation that the branch, there was a statement about the branch campus, I think, that prompted this, that it was a profit-making effort on the part of the school. That was sort of the broad brushstroke that was painted throughout. And then there were specific allegations that the general level of education had deteriorated in the Ross University program, that the clinical sites on the mainland were inadequately supervised, and that they were poor in general quality, and that there was very poor faculty-student interaction, again, at Ross University. I saw it as a statement about the Dominica campus based on sort of reading between the lines, but statements that faculty and students simply did not meet.
So I think it's probably timely then.
So it was concerning, but it was one student.
Right.
But they provided a lot of anecdotal commentary and some documentation that raised questions.
Well, I would have to say the student, what you think, have a vested interest in wanting to make the school look good. So the fact they had concerns, I think, does bear the need for investigation.
Ms. Chang, did you want to?
Just a question. If we approve this campus, later on, if people go to the other one, the main campus.
We already did the other one. The other one's already approved. This is the second.
But, how about the site visit? When he's talking about the site visit, I'm confused now.
Any decision made upon a reevaluation, after a reevaluation site visit would encompass the entire campus.
Okay, so
this is a branch of the main campus, so if a decision is made, taking a guess, you're talking about an adverse decision, because if it's not an adverse decision, it doesn't make any difference. If there were an adverse decision involving the main campus, it would affect the branch campus as well, regardless of the action that you take today.
And the recommendation as posed by staff is to approve the Freeport Grand Bahama campus, and in addition, to recommend a site visit as part of the reexamination or reevaluation by the board of Ross University, which you've already delegated to the task force to look into. Thank you.
So
you move that recommended action.
So before we have public comment, I think we need to have a motion on the table.
I'll move that.
Okay, we need to, let's bifurcate the motion, please.
So Ms. Chang, is your motion to approve Ross University's Freeport Grand Bahamas campus to provide medical education for the semesters 3 and 4, and have that approval be retroactive to its inception in January 2009?
Yes. And I need a second? You have a second for the motion?
Second.
You have a second. Okay, now we're going to entertain any other questions from the board members. Now public comments. And now, Mr. Stefani, if you come forward, I wanted really for you to hear the depth and perception and the accomplishment of the reviewer. We, as a board, I don't think remember having heard such a description of what is the thought process of the expert that is doing this. So I wanted you to hear before you spoke before. So I apologize if I usurped your opportunity, but you have the same opportunity now to speak for 3 minutes.
This particular advisor, we never challenged the qualifications of the consultants, at least their educational qualifications. In the case of one of your consultants, he had a direct conflict of interest that this board knew about. He was on the board of directors, and he was a member of the faculty of one of the schools that this board reviewed, a Caribbean school. He had made public statements that it was the only good Caribbean school, and then he was sent out by this board to examine the schools that he had already prejudged and with whom his schools were in competition. But so I have no doubt that when the consultants actually review, and they do so in good faith, that they're qualified to do it and they make intelligent decisions. My question is whether or not the board staff actually interferes with that process, and whether or not things are delayed and questions are asked that the consultants never asked. You know, that's part of my concern. In the case, but I'm not, and I want to comment on the process of re-review of the schools that we were told about, the schools that are approved. There are 14 schools that this board has reviewed through self-assessment reports, most without site visits, and has approved. Only 14. There are 1,300 schools on the list of approved schools. The board has reviewed nothing about all of those schools with the exception of the 14. You know nothing about those schools. You don't even know where the list of those schools came from. We've already established that in depositions that we've had in another lawsuit that involved a state that follows California's list. You want to re-review schools that you've already had site visits for when you haven't reviewed 1,384 of the schools on your list. You want to put the schools that you've already put through the process through it again after you know about the process, after the school has already gone through the process, after its consultants have already found it to be acceptable, at the same time that you continue to add schools without the self-assessment process through your staff. Your staff has added schools to this list. It was originally 1,200 and about 40 schools only a few years ago. It's grown to 1,300. Schools pop up on your list because your staff puts them there based on telephone calls that they make. We know it because one school that we know that we have intimate contacts with jumped onto your list by a telephone conversation between a staff member and this school. The board has no control whatsoever over 1,300 schools on this list. But you continue to push 14 schools for more and more information and hold them. And the critical part of these schools is that they serve the American population, and Californians in particular.
But you need to really wrap it up. Okay, that's finished. Thank you very much.
I think that the board has to take a long, hard look at its policies. And if the board is going to pretend that it is the gold standard for review of medical schools, that it actually get to the business of reviewing the schools that are on its list, at least understanding how the schools made it to their list, you know, instead of going back and spending the taxpayers' money to re-review and review over again and do site visits again to schools that you've already approved.
Thank you.
Well, yeah, I'm almost...
We're going to have a vote on the motion?
Yes.
As it's stated, okay? All those in favor of the motion as stated, say aye.
Aye.
Any opposed? Okay, the motion carries.
I need to go on the record as abstaining.
Abstaining, okay, we have one abstention.
I wanted to say, you know, you need to have
Wait,
some...
excuse me. We're not going to answer any speakers. Thank you.
I was ready to withdraw my motion after that, but
Thank you.
I think I honored my
Ms. Chang,
decision.
Ms. Chang, please. Different school. Okay, second motion?
Second.
The second part of the first motion, it was we bifurcated it? If you don't?
So moved.
Okay, do I have a second for the motion? The site visit for Ross University? The second motion reads as the staff recommendation to site visit for Ross University for reevaluation by the board. Do I have a second on that motion? Sure. I have any members' comments on the motion? Do I have public comment on the motion? Seeing or hearing none, all those in favor of the motion, please say aye.
Aye.
Those opposed, seeing none, that's going to carry. Oh, I'm sorry, any abstentions on the second one? Okay, thank you. So now we're really ready to go back to agenda item number 30. But I think that it's time, Mr. Wharton, if you're willing to come back to the table for us to take 20 minutes, half hour max, and have a slight break. So that
Yes,
I might
that's
have
fine.
more patience, not less patience. Yes. Didn't we do yesterday? What did we not?
Renewed 2111s, 5 renewed on 2113s, and that's it. So, as far as we've scheduled the special faculty permit committee meetings for the following dates: Thursday, March 24th, 2011, from 10 to 11:30 a.m. Thursday, June 16th, 2011, 10 to 11:30 a.m. And the Thursday, September 15th, 2011, from 10 to 11:30 a.m. Those meetings will take place if we have applications that are need to be reviewed. We currently do not have any 2168 applications. So.
Okay, thank you.
We currently have 6 international medical school applications pending, minus the roster review approval makes it go down to 5. We have received 16 midwife license, 12 midwife applications for the first quarter. We have 4 pending, 9 renewed, or 9 issued and 30 renewed. So, optical registration licenses are sort of self-explanatory. I won't go into those too in detail. And the research cycle analyst applications, we received 3 and we issued 2 for the quarter. Fictitious names permits, we've received 310 requests and issued, we have 66 pending, and that were issued, and 66 are pending, 7 are for podiatry, and 1 podiatry is pending. And we have 1 specialty board application and review. And that concludes the report on the chief's report.
Thank you very much. Ms. Scurry, would you please come forward and make your report?
Actually, really, Mr. Wharton.
Okay, would you please sit with Mr. Wharton and share the responsibility of informing the board of whatever the two of you have decided to inform us about?
So we're going to go over the application review process for probationary licenses. Ms. Scurry and I will be explaining the application review process that results in an offer for a stipulated agreement for a probationary license. First, I'd like to provide a brief overview of the staff's investigation of an application to determine whether the applicant meets the education, examination, and training requirements defined by statute and regulations. Staff must determine if the applicant failed to disclose required information, such as criminal convictions. A check and balance process requires comparison of the rap sheets and with the application. Staff must also determine if the applicant has any out-of-state discipline. They do this by reviewing AMA profiles for the National Practitioner Data Bank. And also, staff learns from the application that the applicant has been put on probation, received warnings, and been terminated, not had a contract renewed or resigned in lieu of discipline, etc. In one or more of the residency training programs, staff must then investigate why, collect the necessary documentation. In addition, staff must have to coordinate evaluations for applicants who may have a mental or physical illness that might impair their ability to practice medicine safely. Usually staff learns of this information from the applicant's self-disclosed history in the application or from investigating gaps in residency training or other reports of the applicant's inappropriate behavior. Substance abuse is usually either self-disclosed on the application or indicated from a criminal conviction or on the other documentation that the board has received during the investigation of the application. These conditions may require an evaluation to determine whether the applicant can practice medicine safely. Lastly, staff must determine if an applicant has been away from practice of medicine for a period of time. Usually this is determined from information provided on the application or due to discipline elsewhere, and consider whether senior staff should require the applicant to take a specs exam or take PACE to ensure that the applicant's fundamental medical knowledge is sufficient to practice medicine in California. Staff goes through all these steps to fulfill the board's statutory requirement to protect the public. The board has an obligation not to license physicians who may pose a threat to the public and health and safety. When staff performs the initial analysis of the application and identifies an application with concerns, the application filed is submitted for SR1 review. This is a collaborative effort with the licensing managers and the chief. If it is determined that a free and clear license is inappropriate, the applicant is raised to an SR2 level for continued and further processing. A senior analyst further investigates the application file, obtains any other documentation that is necessary, and prepares the application and supporting documents for review by senior staff. Senior staff consists of executive management, licensing managers, DCA legal counsel, and a deputy attorney general. During this process, it is determined if the denial is warranted and whether sufficient grounds exist to deny the applicant.
SR2 cases are really complex cases, and they take a lot of additional time, significantly more time than do the regular cases where someone proceeds to licensure. Just as in the discipline process, each application is reviewed on a case-by-case basis, and the decision depends on the specific facts of that application. So, for example, when denials are generally recommended, it's because the applicant has a recent substantially related criminal conviction, or there's some evidence of serious misconduct, could be dishonesty or fraud, or an uncontrolled mental illness or substance abuse issue that may impair the applicant's ability to practice medicine safely. Staff, when they are faced with one of these situations, and most of the information is picked up on the application itself because of all those questions that are asked. A significant number of questions are asked about the applicant's performance in postgraduate training, about criminal convictions, discipline in another state, and so forth. So the staff obtains all these documents, and sometimes the file will be that thick. If there are a lot of postgraduate training evaluations in there because maybe the individual has some performance issues or professionalism issues, staff reviews and analyzes all those documents that come from different sources. The most common are court records and postgraduate training records. And as I said, they can be very voluminous. The applicant has the responsibility to obtain the court records, and the board staff generally asks for the postgraduate training records directly from the institution itself. And your staff is really very diligent. They truly do their job of reviewing these records in light of the board's mandate to protect the public. They take their public protection mandate very seriously. I can vouch for that. When we say that Mr. Hepler and I sit in on these evaluations, it's true. I look at the cases that would go to Mr. Hepler's panel, and he looks at the cases that would go to the panel that I advise, so that we are very sure that we have no role in the prosecutorial or other sort of functions leading up to those cases coming to that particular panel. So I just wanted to make sure that that was clear.
Okay. Once senior staff determines whether the applicant's actions justify an outright denial or if an applicant should be offered a stipulated agreement for probationary license with appropriate terms and condition, then the senior staff decides to offer the applicant a probationary license. The lead analyst prepares the stipulated agreement and the correspondence that goes along with that, offering the applicant the option of a probationary license. The applicant has 60 days to agree to the stipulated agreement and return the signed stipulation or request an administrative hearing. When the board receives the signed stipulated agreement, it is reviewed by me to ensure there have not been any changes made, and then I sign the stipulation. The signed stipulation is then prepared and forwarded to enforcement for processing of the stipulation to the members for vote.
So, of course, as we discussed yesterday, I think it was yesterday, seems like a long time ago, public protection is the board's highest priority when it exercises its licensing functions. And your staff takes this mandate to heart, and I know that you also do. Since the one thing we do ask that you keep in mind is that when you're reviewing these licensure cases, the burden of establishing fitness for licensure rests with the applicant. And that is a very critical difference between applications and disciplinary cases. And if the staff isn't diligent at taking care of them at the initial stage, then you will be seeing them later as a discipline case. But they do review these. It's a very thoughtful process, if I can say that. Having sat in on many, many of these over the years, I think people take their mandate for public protection seriously, and yet at the same time, they're trying to balance the needs of the applicant when that's appropriate.
In closing, I'd like to remind members that they could vote timely on these, because most of these applicants that we're offering a probationary stipulation for licensure to, they either are in postgraduate training and they are need their license to continue in their training, or they have been physicians who have positions pending in California. So if we don't have a timely vote and we're not able to respond to the applicant which way the vote is going, then we have a delay in that process, and it could affect their position here in California, where if they don't get time, because they're, especially in postgraduate training, sometimes they will terminate them if we can't give them a definite answer whether or not they're going to give probation.
Is there a specific time during the year where you feel that there is more of these probationary applications coming forward that people should be maybe more aware of, looking at their emails? I mean, I would recommend that members look at emails at least once a week, but maybe there's a specific time of the year that you want to warn us about that maybe they're coming through much more quickly.
I don't know if there's a specific time of year, but as postgraduate training comes around, they have their limitations for how long they can practice without their license. It's 2 years for U.S. grads, and it's 3 years for international grads. And so sometimes the people who have these issues, they delay applying, which puts a time crunch on everybody. So I wouldn't say there's a specific time, but it's because we review these on almost a weekly basis. So.
Are there any questions from any of the members?
Can I just say one last thing? I think one of the purposes of this presentation is to show you the process that the staff goes through when they present a probationary license stipulation to you. It's not something that's just sort of tossed forward It's gone through multiple reviews before it finally comes to you, and we just thought we would share that process with you so you could understand how it gets to you at the end of the application process.
Thank you. I have a public comment from Mr. Sheep. Would you like to come forward and speak on this, please? Thank you.
When the applicant applies for license, there are several forms, L1, L2, L3. One of the forms is L3B, and there is a statement on second beginning of L3B is signed by the program director under penalty of perjury. Definition of satisfactory completion of training. The program director signing this form is certifying and documenting under penalty of perjury that the trainee received instructions appropriate for a particular postgraduate level and that she satisfactorily completed period of training in accordance with the accepted standards and the criteria defined as equating to satisfactory performance as described below. So there are some criteria. The program director will personally be attesting to the fact that the trainee has acquired the skill and qualifications necessary to safely assume the unrestricted practice of medicine in this state, and there is a criteria definition of satisfactory. I just heard that medical board has a right to get educational material documentation from the residency program, and in one particular instance I am particularly aware that the medical board did that, and the residency program director, whole hospital residency program, GME, I heard that they have made a policy that never ever give residency program records, educational records to the medical board because of certain issues. So my question is, number one, when the doctor is certified by the residency program director that the doctor is satisfactory, is competent, does the medical board has any authority to challenge the qualification of a physician? I mean, that's the educational institute, University of California, that is saying, hey, you know what, this physician is qualified. And the medical board come back, hey, you know what, we think that's wrong. Let me have the documents and review that information if the physician is competent. So number one, does the medical board has authority? And number two, in one circumstances, the medical board will exercise its authority to request the documentation from the residency program.
Thank you, sir. So we're going to, with no other additional comments, going to move on the agenda to agenda item number 31. Ms. Ehrlich, would you please come forward? Make your report on the Midwifery Advisory Council.
Hi, pleasure to speak with you. We had our last Midwifery Advisory Council meeting in August. Among the things that we had at that meeting was a presentation by Claudia Borrelia, who's the president of the California Association of Midwives, on the barriers to care that midwives face in the state. And those barriers to care, I believe, are making women and babies more at risk because they prevent us from having the tools that we need in order to safeguard them. Certainly that stems from supervision, the requirement for supervision that is unavailable in the state of California. I would like to ask that the issue of supervision be placed on our agenda for the next Midwifery Advisory Council meeting in December so that we can try to do some strategizing about how to make this work for California midwives and most importantly for California's mothers and babies. Because indeed, midwives also have as our primary concern the protection of the public. The current system is not protecting the public well. Among the things that we also are doing is the Licensed Midwife Annual Report. We are closing now the last couple months of the 4th year where we are going to be making this reporting. And I think that the issues that have come up about the statistics that we are getting in that report indicate to me and to many of us that we are not getting good information, that I think that the limitations of having retrospective reporting, which any epidemiologist will tell you is not anywhere near as good as prospective reporting, that the limitations are really showing us that we are not being well served, I don't think, by the current system of having our annual reporting. It is possible that we could contract with others who are doing reporting throughout the country, who are doing prospective reporting, meaning that when a midwife takes on somebody in her care, she registers that birth ahead of time so that it can't get lost. And then at the time that data is collected and processed, if there are discrepancies, the data are validated. They are verified. There are systems that we could possibly contract with to do that. And I think that OSHPD, given the budget limitations and the staffing limitations, is really not going to be able to do that. So if we are going to be able to get some decent statistics, and I mean, what we have shows that I believe the midwives in California are doing a good job. And I believe that the discrepancies we're getting call all of it into question. We really don't know whether we are getting adequate data to be able to help us to understand how midwives are doing in the state of California. It would also put us into a context of national data, which currently shows that midwives do very well in out-of-hospital settings and with home births and freestanding birth centers and as autonomous practitioners. None of the other states in the U.S. that have licensed midwives have supervision requirements, and those stats are all quite excellent. So it would put us perhaps more into perspective. We could extrapolate not just the California data, but we could also then put it into the context of how we are doing as in comparison to other states and to the rest of the country. So that is another issue that I would like to ask be placed on our agenda to be able to discuss. Among the issues that we have, the Comprehensive Perinatal Services Program, which was put together specifically to serve low-income women, pregnant women in the state of California, does not have on the list of providers licensed midwives. It's one of the ironies of how care has gotten developed over the years, because the Comprehensive Perinatal Services Program, or CPSP, was put together as a midwives model of care. It was because there had been some good research that showed that the kind of care that midwives give helps outcomes. It lowers prematurity rates, it improves good nutrition rates, it improves breastfeeding, it improves a lot of different parameters that were looked at. And yet, licensed midwives are not on the list. I would like that placed on the agenda so that we can perhaps begin to discuss how we can get CPSP authorization for licensed midwives. It has come to my attention that a section of our law, our enabling legislation, SB 350 of 1993, which included a section at the time it was labeled 2514, which authorized the educational parameters that were granted to programs and to midwives who were going to be licensed in the state of California. It offered a parallel set of educational standards to certified nurse midwives. That was the intention of the legislative author, Lucy Calais, who put that bill forward for us in 1993. Those educational standards, none of us noticed because we were so concentrated on implementing SB 350 from 1993 to 1996. None of us noticed that that section was due to sunset in 1998. For the last several years, I've been trying to find that section. Every time I look in the law book, I go, it's got to be here. I know it was in here. And I haven't been able to find it. And then a couple of months ago, I found a copy of the original law as it was passed and chaptered. And indeed, there it is. I have now come to understand that there has been a new section that has been put into our bill that has taken the place of that, so we can no longer call it 2514. I would like us to be able to discuss in the Midwifery Advisory Council how we can go about getting this particular section of our bill repassed, because I think it is essential to the educational and practice guidelines for midwives that this be put back into our law. When the Midwifery Advisory Council was passed, in legislation. The medical board at the time chose the categories of people to whom who would be welcomed as members of the Midwifery Advisory Council. The law said that at least half had to be licensed midwives, and that I don't remember exactly what the law says about who the other people were supposed to be, but the California midwives always imagined that one of the public members that was mentioned was going to be a public member who had been taken care of by a midwife, was going to be a parent. And that did not happen. When the council was empaneled, we had 3 midwives and a 6-member panel. We had 3 licensed midwives and 2 obstetricians and 1 member of the medical board. Over these years, it has become clear that one of the seats that an obstetrician has filled often goes unsat. It is quite common for that second obstetrician to not show up or to be unable. I mean, they're busy people. These are people for whom the Midwifery Advisory Council, I cannot imagine, is quite on their priority list. And they end up perhaps resigning before their terms are done, or they end up not coming to the meetings. If we get to a place where we have an open seat in that public section, I would like the medical board to consider renaming that position and having us recruit and have applied for and have a selection process so that some parent, whether it is a mother or a father, who has been served by a licensed midwife in the state of California could be placed on the Midwifery Advisory Council. And that's only if a seat becomes available. I realize that we're not talking about being able to add seats. I understand the limitations of the budget on those terms. I'd like to also remind the medical board that most of us who are licensed midwives in the state of California also hold a credential called the Certified Professional Midwife. And that is a national and sometimes even an international certification by an organization called the North American Registry of Midwives. The credential has been psychometrically designed and continues to be updated constantly. I would like the medical board to know that in healthcare reform that was passed, that certified professional midwives are now on the authorized list for Medicaid reimbursement in freestanding birth centers, in licensed birth centers. So it is becoming a federal impulse to recognize and authorize certified professional midwives. We do not have Medicaid ability here in the state of California for the licensed midwives because of the supervision clause, theoretically. I would like the medical board to realize that there are states in the U.S. where Medicaid does reimburse certified professional midwives, and that it is a movement that will continue to happen. There is currently now a follow-up legislation in Congress that will authorize Medicaid reimbursement in all settings for certified professional midwives. So this is coming. This one is kind of the most upsetting of them. There was a midwife in, I think, Southern California within the last couple of months who was taking care of a woman who had had a prior cesarean. And I hope that you all realize that although it is standard of care that we refer women for medical care if they have prior cesareans, there has also been stipulation made in our scope of practice that if a woman refuses to be medicalized, that we may continue to take care of her. This particular midwife had a woman in her care who was a VBAC, vaginal birth after cesarean, and she went into labor and did not progress. Nothing was actively wrong with either mother or fetus. They were both fine. The midwife transferred her to the hospital, where she did undergo a cesarean, and both mother and baby are fine. The medical staff there called the police and told them to come and arrest her for attempted murder. I hope that perhaps the medical board could put something into the newsletter that will let people know, medical people in the state of California, that we are operating within the terms of our license. That for the police to be called is wasting public safety dollars, and it is harassing mothers and parents and families who make a rational decision for themselves based on research and evidence. So I would hope that this could be something that perhaps the medical board could address. That is, I believe, the end of my report.
Thank you.
Just to inform the members of the board that might not be aware of it, that the Midwifery Advisory Council needs to come to this body to request items to be placed on the agenda for discussion. They're not for implementation, but for discussion. So to that, I would recommend that Ms. Ehrlich has asked for us to have placed on the agenda for discussion only the issue of supervision, the issue of prospective versus prospective reporting,
CPSP authorization.
And I would venture to say that's enough to start with, right?
Well, it is, and to continue the whole barriers to care
barriers to care,
discussion,
right,
which
based
I
on
think
barriers.
actually should be an ongoing agenda
Well, the
item.
2514.
And 2514, yes.
So to that, let's start with those, okay?
I think so.
The meetings are only 2 hours long. So I would like a motion to allow the midwifery, to that go forward with that discussion.
Okay, so move.
Second.
Okay. So now do I have discussion on the motion from any members of the board? I don't have any public speaking.
Madam President, would these issues go first to the midwifery advisory?
Right.
And then from the advisory, then it would come back?
Right, it comes back. So to that specifically, to those issues, Claudia, did you want to speak, or did you want to speak in general?
I want to speak about the barriers to care.
We're moving to a motion forward to allow the discussion at the Midwifery Advisory Council. Are you speaking to the motion? No. Okay, so all those in favor of the motion, say aye.
Aye.
Opposed? No, okay. So that goes forward. Now, as far as public comment, I have a request from Claudia Breglia to speak on item number 31. Please come forward. You have 3 minutes. This is not a conversation. This is just a...
Thank you.
Thank you.
I'm Claudia Brelia. I'm a licensed midwife and the president of the California Association of Midwives. I believe that you all have the packet on barriers to care that I provided at the Midwives Advisory Council meeting. Just in general, the barriers are listed with evidence on the left-hand side, and potential solutions are on the right. Granted, supervision is a major issue and one that needs to be addressed, but right now I just want to clarify a couple of less contentious items. California has already made a move to incorporate collaborative care in addressing healthcare disparities in obstetrics. Licensed midwives, nurse midwives, and physicians have come together to create federally qualified health centers that provide community-based prenatal care and family planning to low-income women. And in some areas, they've completely replaced the county free clinic system. The problem is that licensed midwives were never added to the lists of providers of obstetric care. In both the CPSP, the Comprehensive Perinatal Service Program, but also the Family Planning, Access Care, and Treatment Program, which is also known as Family PAC, and has had a significant impact in reducing teen pregnancy rates. Licensed midwives are designated Medi-Cal providers in Section 51051 of Title 22 of the California Code of Regulation, and were covered to the extent that federal financial participation is available in Section 14132.39 of the Welfare and Institutions Code. These clinics provide services within our scope of practice and are also under physician supervision. But since we've been left off the lists, licensed midwives are being fired, even though in many cases they've been instrumental in creating the clinics, and their lawyers are now telling the clinics not to hire licensed midwives because the clinics can't bill for our services and can't be reimbursed. Similarly, as Ms. Ehrlich pointed out, the Affordable Care Act allows for reimbursement of certified professional midwives, which is our national certification when we're working in state licensed birth centers. California birth center law requires accreditation by the American Association of Childbearing Centers, which includes a physician, medical director, and strict practice guidelines in their accrediting requirements. California law requires that two people be present at all time when a woman is in the birth center in labor, and that one of those people present be either a certified midwife or a physician. So until the title licensed midwife is added to that list, licensed midwives can't be hired by licensed birth centers, since we're not legally authorized to provide midwifery services within our scope of practice under the supervision of a licensed physician. And that's it.
Thank you very much. Thank you for your report. I'm going to move on the agenda to item number 32 and ask Ms. Threadgill to please come forward for Enforcement Chief's report. Ms. Threadgill?
Good afternoon.
Good afternoon.
If I may refer you to agenda item 32A, may I have a motion to approve 17 orders to restore license following completion of probation and 3 orders for surrender of license during probation or administrative action.
Have a motion?
So move.
Second? Second. Any discussion on the motion? Any public discussion on the motion? Seeing and hearing none. All those in favor, please say aye.
Aye.
Opposed? Abstentions? Fine, done.
And before I get started with the rest of my report, I'd like to acknowledge the staff who are here from varying offices in Southern California. If I could get you all to stand. Oh, yeah. That's right. Okay. Thank you. I won't name them. They will remain nameless. Agenda item 32B on page 237 reflects the use of 556 experts by specialty during the past quarter. Please note that the number of experts in our database has increased to 1,207 since the last quarter. And the number of experts in most specialties increased as well. The program received over 120 applications following the July newsletter advertisement. So we are busy processing copious amounts of applications for the expert reviewer program. And we're also working busily to get the training program in place that will improve the quality of the work they will be able to do for us. And Laura Sweet, our Deputy Chief, will report more on that in January. The enforcement program has a vacancy rate currently of approximately 10% for supervisors and 7% for investigators positions, which is approximately 7% overall. To put this rate in perspective, staff conducted an informal inquiry regarding vacancy percentages at 12 other agencies and learned that rates varied from as low as 4% to a high of 56%. 5 of the agencies had a vacancy rate from 10 to 13%, and 5 other agencies had vacancy rates of 18 to 35%. Normally, we recruit and hire from an open list to fill investigator positions and a promotional list to fill the supervisory positions. Currently, as a result of the hiring freeze, we are only permitted to hire via transfers from within the department. Also, we cannot promote individuals to backfill positions. As previously reported in Ms. Whitney's report, we won't be filling the CPEI positions under this freeze as well. This is particularly important to us at this time because we are aware of potential retirees at the end of the year that are supervisory positions, as well as one of our supervising investigator two, who has a key position in our training unit, will be leaving us as well. And we are going to be facing an impossible situation. So I just toss it out. If there's anybody who can make this freeze disappear, I'm calling on you to feel my pain.
I don't know, a well-placed article in the LA Times or the San Diego Union might help you a lot.
Well, would you take care of that?
Well, you have to give me some evidence-based.
Okay. In an effort to remove perceived obstacles to investigations and improve communications, the enforcement management team and HQE convened a meeting with Kaiser South earlier this year. On September 20th, we held a similar meeting with Kaiser North. Both meetings were extremely productive, and we are hopeful that we have reached resolutions that will help improve the investigative timeline. Some of the things that we're going to be working with changing. Kaiser North is working on centralizing a point where we will be able to get records then. This is a little bit down the line, but it'll make things go much faster to have a single point for requesting and receiving. We continue to utilize the Age Case Council to move cases that appear to be stuck. Our experience with this process to date has been that mere identification of cases that will be subject to council produces movement, so that it has been helpful. And we have a number of things that are projects that are going on now that involve training that is scheduled. One is the Mini Academy, which will be held over a period of 3 weeks. 1 week in November, starting the 15th, a week in December in San Dimas, and a week in January. I will be providing Ms. Whitney with a copy of the courses that will be taught at each of those segments, so that if any of you board members would like to stop by, say hello, just see what we're doing, you'll be able to pick the classes that might be of interest to you. So I will have that to you so you can email it. There's also the statewide investigator training conference that we're hopeful we will be able to complete in April of 2011 that staff is working on. At this time, I'm going to turn the mic over to Carlos to do his vertical enforcement report.
Good afternoon. On October 19th, I met with Mr. Frank Sarunian, your Executive Director, Linda Whitney, and your Chief of Enforcement, Renee Treadgill, to discuss some of the findings in the Frank report. One of the items that we discussed were the costs associated with vertical enforcement. Mr. Sarunian has asked for data from our office. Some of this has been provided, and as soon as it is determined who my next boss is going to be, I believe that we will be making an appointment to meet with executive staff from the Department of Justice and continue this dialogue. With regards to the Frank report itself, even though I disagreed with parts of it, there were some parts of it that caused us to re-examine the way we do business statewide. And some of the findings were known to me as far back as March of this year. So since the latter part of March, earlier part of April, we have taken some measures to address some of the concerns in the Frank report. In the ensuing weeks, maybe months, I plan to meet with Renee Threadgill and perhaps revise the vertical prosecution manual to reflect some of the best practices that are used throughout the state, and and implement the program in a more consistent way statewide. There are reasons why it's implemented differently in LA. I'm not sure that anyone has the time or the interest at this point, at this time, to actually get into it. But if you do, I will. If not, I will continue. We have added a third. We have 22 DAGs, deputies, in the LA office, the largest office of any of the HQE offices. Up until recently, the deputies there were supervised by 2 supervisors. The ratio was of 1 to 11, which is way higher than the office would like to have it. The office recommends that the ratio of supervisors to deputies would be 1 to 6. I have received permission to hire yet another supervisor to actually bring the ratio of SDAGs to DAGs lower and more in conformity with the rest of the office. We have recently appointed 1 new supervising deputy attorney general. Her name is Gloria Castro. She's a graduate of USC. It pained me to appoint her, being a graduate of UCLA, but we have to do what we have to do. Let me see.
It's under question, don't worry.
I believe that's all I have for now. If you have any questions, I'll be more than glad to answer them. Yes?
This is probably something I'm going to ask anybody privately, but a colleague had asked me how long a physician, particularly after retirement, should be hanging on to records. With electronic medical record, that'll be different, but a lot of people still have a backlog of hard copy. The hospital, we're told, takes records for 7 years. This colleague was told that checking with the malpractice carrier, they should keep records for 25 years. What is the realistic?
Nutrition
is different, but just in general.
It's extremely difficult to answer that because there are statutes regarding certain types of records, like prescription records, records, drug logs, things that you might have to hang on to longer than others. But if you're looking for a good guide, CMA does a pretty good breakdown in their physician legal handbook. If you have any more further comments or questions, Carlos, I'll continue with my part of the VE report. First, I didn't refer you to page 245 where the vertical enforcement statistics are. But I'll just let you look those over yourself. They pretty much speak for themselves. I was pleased in reviewing the report that was presented earlier by Ben Frank. I was pleased to note that we are already in process of implementing several of the items. And these items have been in process over a period of time. Video conferencing, as you know, we had to terminate what we were doing with that, but we hope to resume work to achieve some form of video conferencing again. We also had an augmentation for additional med consultant hours, and we intend to pursue augmentation further, even though we were not successful with the first round. We also had begun improvements to the expert reviewer program, and those continue to be developed as I reported earlier. We are continuing to work with Carlos and the SDAGs, and next week we have a conference call scheduled to discuss improvements to default decision processing. We're continuing to identify areas of concern and best practices that will improve the timelines, and Carlos has already mentioned some of the things that those include, such as the updating the manual and our expert utilization policy. We need to explore some alternatives in that area. That's my report, and unless you have any questions, I would like to put the mic to rest.
Any questions from any of the members? Any public comment? I'd just like to remind the audience, in case they weren't quite sure, that, oh, I apologize, I will wait to remind the audience.
That's quite all right. Go ahead.
That LA County is a rather big county in the state of California. It takes care of about 10 million people plus. So the idea that you've got more going on in LA, it sounds fair to me. So I just wanted to put that out there, not for comment or editorialization, but it's a fact of life. There are more people that live in LA County than the rest of the state, probably combined. So
Venue for physicians' cases is Los Angeles, and the venue extends from Bakersfield down to Orange County.
So even bigger than LA County. Thank you. Okay, Mr. Zerani, you wanted to make a comment?
Well, thank you, Madam President. The only thing I wanted to say is the numbers that we have in our enforcement remain high, but I'm not going to specifically comment on them because I really do appreciate the effort that staff has put in looking at the report. As I said, the report represented a great opportunity for us to look at various efficiencies or inefficiencies and for us to work together. And I want to publicly thank both Renee and Carlos for right away listening and engaging. And I therefore will refrain from making any specific comments because I think we need to give it, for the first time, I feel as though we're making progress. And I think that it took me 4 years to say this, but
it's a big deal for Frank to saying this. I want you all to have heard what he said.
It's a good thing, but I really do appreciate the efforts, and I think that there are certain things that Carlos could deliver. There are certain things that he couldn't deliver. I appreciate that. He told me from day one, and we need to get to the right pay grade for some of this stuff. But we have specific ideas as to how we can advance this and make it much more efficient for all of them. And I appreciate your cooperations.
Thank you. I should like to make one comment, and I believe that some of the improvements reflected in this latest report, and I think Renee's staff and her staff should be congratulated on the improvements made in the enforcement program, particularly on the investigation side of the.
Wow, we're going to have a mutual admiration society here soon.
I've got to echo. I was just sitting here
Wow.
thinking that I hadn't had a chance.
This is a big day, board members, a big day.
I have to acknowledge and recognize the hard work of all of the enforcement staff, from the complaint unit to the probation unit. And in fact, one of the good things that I can tell you that I didn't share earlier was that we had had a problem with petition investigations in the past being a little slow. And I'm pleased to report that they are all cut up. The last, there are only 3 outstanding. The last investigation, petition investigation, was assigned out last week. So that makes me feel really good, and I'm really pleased with all of the district offices. They've continued to perform at a high level, even though things have been quite challenging.
Thank you very much. Oh, Dr. Solomon?
And I got that email about the Investigator Academy, and I think that I'd like to try to attend, but do the expert witnesses that might be testifying, do they know about this? Because this could be useful for them, maybe, to know, or you think it's not appropriate for them?
There's 2 different things. The experts need to be trained in delivering the product that we need in order for Carlos's staff to do a better job. The investigators need to be trained to get the information to give to the experts so that Carlos's staff can do a better job. Although it would be interesting, I don't think it would be productive for them to participate in that.
I just think the medical experts, in my opinion, could benefit from some law knowledge in terms of,
but that's
gross negligence, and some of these terms that, from what I see, the medical experts may not have the legal terminology.
That's part of what Dr. Lowe is working on with us in the Enforcement Committee, developing that interactive training that will hopefully take us to where we want to go with our experts.
Okay, thank you very much for the report. Thank you, members. I'm going to, yes, sorry.
forgot one thing in my report. May I take another 2 minutes? No. Okay.
Sorry, unless you're asking for an action item, there's no...
Yeah, I mean, it's to add into the agenda.
1 minute.
Okay, 1 minute.
So going back to agenda item number 31.
And this has to do with the licensed midwife annual report. There have been a couple of times in recent years where there has been a mortality that a midwife has reported, that when it has been revisited, it turns out that she entered that inaccurately, that it was actually an incorrect thing, that there was no death. But OSHPD will no longer do any validation of that. So what we have been trying to do is figure out how to expand the questionnaire so that if a midwife states a death, that she will then be asked to answer a whole set of other questions so that we can really find out what is going on. Faith Gibson has written a preliminary additional questionnaire. I can see that it's probably not going to work to get it into the report for the 2010 annual report, but it does need to go into the agenda so that we can discuss it on the council and see if we can get this additional information.
I don't believe you need any approval from the board to proceed with matters relating to the report.
Okay.
Because that is something that is assigned to you already.
All right, thank you.
Okay, what I'm going to do now is move and put on hold item number 34 on the agenda. I was unaware that Dr. Moran had some input or involvement in that, and she's had to leave to see a patient. So we're going to put 34 on the January list of things to do in the board. So we're going to move on to number 35 and ask that Ms. Kirchmeier, a representative of the Department of Consumer Affairs, join us at the table and speak to us.
Try.
We might not like it, but speak to us.
Okay. Good afternoon. I'm here today on behalf of Director Steger to provide an update on projects and matters of interest at the Department of Consumer Affairs. And one of them, Ms. Whitney has actually already briefly touched on. I just want to provide a little bit more detail. On August 31st, we did receive a governor's directive to cease the hiring of employees. The department is complying with that directive. The directive did actually state that there may be limited circumstances where exceptions to this directive may be necessary for the preservation and protection of human life and safety, emergency and disaster response, the provision of 24-hour medical care, and mission-critical functions. As we've found out, the exception process has to go through the department, it has to go through the State and Consumer Services Agency, and also through the governor's office. It's very stringent, and only the most critical requests are being approved. We have submitted several requests for exemptions from the hiring freeze, and as of today, we've only had 5 exceptions approved. And just to kind of give you a little bit of background so you understand which ones are approved, those were really for overtime. We had the San Bruno fires, so for contractors, they were allowed overtime to go in and assist with that emergency. We also had an examination that one of the agencies provided, and so they needed overtime for their staff for that. For Athletic Commission, they've gotten overtime because they hold events on the weekend, and so they need that very important overtime for their staff to be able to do that. And then also, as some of you may or may not be aware, the Bureau for Private Post-Secondary Education, which approves the schools, those actually, they had a bill that was put in, AB 48, to make that effective January 1st. Unfortunately, they didn't have the staff, and so the hiring freeze struck them the most severe. They had, I believe, their budget change proposal was like for 72 positions to bring that up and running, and they weren't able to hire those individuals. So we were just recently notified that we have been given an exception for that process, and they can only hire, though, licensing and application individuals. So those are the exception requests that have been approved so far. So as you can see, out of the numerous that we've submitted, they're really looking at it strictly. With that being said, we did notice that there seemed to be overtime seemed to be something that was being approved. So we actually wrote out to the boards, and Ms. Whitney received an email. Basically, with the Consumer Protection Enforcement Initiative, the fact that we aren't able to hire those positions, we actually asked for overtime? Is there anything that could be done with your existing staff that could help implement anything with CPEI or help definitely decrease the timeline for investigations, complaints, et cetera, within your existing staff? So that's going to be the next exception request we put forward, is anybody that has submitted time for overtime. I know it may not help so much for staff, it may help with investigative staff to be authorized for overtime, but other than that, that's what we're putting forward right now.
If I can clarify that, it was for the front end or what the CPEI staff would do, not in the investigation arena. That's all we understood would be for staff that would do the same duties that the staff for CPEI would do.
My recommendation at this point, and I will go back and check on it, but my recommendation would be to put in overtime for your investigative staff in order to bring your time frames down. I would definitely put that forward. Okay. Yes. And I'll go back and check that, but that was my understanding, and that's not the first time I've said that. So I would.
But just so you know, how they sent it out was to compensate for not getting the CPEI positions.
Okay.
So one would assume that that would be for those individuals who would do those same jobs. And that's how we interpreted it. So you may want to let the rest of the department staff know, too.
I will definitely let them. And my thinking behind that is actually with the your non-sworn investigators would have been able to come in and pull some of your workload from your investigators to some degree if you were separating those out. So therefore, in order to not do that, you can't do that right now. So you need overtime for your investigative staff to be able to move those cases forward. So you'll take. I'm
Can
trying
I
to
just
feel,
ask you for further clarification?
I'm trying to feel Renee's pain.
Well, you're going to feel it less when you answer my question.
Okay.
The ability to put the entire staff for a certain period of time on overtime, understanding that the entire staff works together as a community to make sure the mission of the medical board and the people of the consumer of the state of California are in place. I'm not suggesting we give them a pay raise, but I am suggesting that you consider allowing Ms. Whitney to put the entire staff on overtime for a specific amount of time.
Okay. And again, that will come through the request, and we'll definitely put it forward, and that's what we're going forward with right now, is one for overtime for individuals. Okay. The department has also been notifying the boards of other changes to the budget, and I believe Ms. Whitney kind of touched on those. As we are notified by the Department of Finance, that's something that we're notifying the boards of so they understand and know what the impact is to their current budgets for fiscal year 2010-11. Okay, moving on to the Consumer Protection Enforcement Initiative. We continue to encourage the board to move forward with any regulations that would allow the executive officers the ability to expedite the board's investigation and prosecution processes, as identified during the drafting of Senate Bill 1111. I've looked at the 9 ideas that were brought forward and that legal counsel said could be done through regulations, and I believe 7 of them, or actually 6 of them, came from the medical board. So obviously you don't need to implement regulations on those, but there were about 3 of them that the board doesn't do from my review. One of them you actually just picked up through your legislative proposals, the one for individuals that don't comply with you during the investigation stage, but I believe there are 2 other ones that the board may want to look at and then subsequently go through the regulatory process in order to help them expedite the process. You want them?
Would you let us
Yes.
know what they are, please?
They are the psychological or medical evaluation of an applicant, putting that one into regulation, and I've seen that language. I know that currently you do that. You might want to put that into regulation. That's one of them. And then the other one is failure to report an arrest. That's the other one that I see that the board doesn't have right now. You have obviously to do indictments or felonies, but we're also looking at arrests, and that's one thing we've asked for.
Are you asking that that be declared unprofessional conduct?
Yes. Yes, I'm sorry, Anita. Yeah.
Well, I thought maybe you wanted them to be going out and arresting people.
And it's actually the requirement, and that's what, in looking at the language, I believe, Nita, it states that they have to notify the board of an arrest.
We have mandatory reporting now in the state of California. What you're suggesting is that those people that are mandatorily, or that have to mandatory report are not doing so, and you want to do what?
Right now, for the medical board, you have to report felony convictions, misdemeanor convictions. However, you don't, and you also have to do indictments, which is for a felony. You don't have to notify the board of an arrest. You do have subsequent fingerprints, but in order to expedite the process to bring them into the board quicker than maybe when you would be notified through a subsequent arrest, we're asking the boards to have licensees notify the board of arrests.
Well, let's take it under consideration, because I thought we, thank you.
So those are the two now that you're down to. The other thing we're doing is we are moving forward to get the paperwork ready to fill Consumer Protection Enforcement Initiative positions as much as we can. We have drafted actually a document for the duty statements for some of those positions that the boards can use, and we're hoping that as soon as the hiring freeze is lifted, we will be able to move quickly to fill those positions. So we're moving forward on that, even though we do have the hiring freeze. We've also begun to obtain information on performance measurements. As I believe we've stated here before, these would address cycle time, volumes of complaints, cost, customer service, and probation monitoring. This information is going to be posted on both the medical board's website and also on the Department of Consumer Affairs website, so the public can go out and see those. You should be able to see those in probably mid-November on the departments and the board's website. And we would really encourage you to go out and look at it. The biggest one, obviously, that we've found, according to the public, what's the most important to them is how long it takes from the complaint initiation all the way through to the disciplinary action, and that is one of the measurements. So we'd recommend that you go out and look at those. And then the next item, as you may know, the director has been holding monthly telephone calls with board chairs and presidents and the executive officers. And during one of those calls, a discussion came up about protocols for the board meetings. So on page 247, under tab 35, the Deputy Director for Legal Affairs, Doretha Johnson, actually developed board meeting protocols, and those are listed in your packet. The protocols are intended to assist the boards in knowing how to conduct a board meeting, and it also includes some scripts that could be used in any other ideas about handling public comments, some other ideas there. So unless there's any questions on that, that's all I have on that agenda item. And then the last is the update to the BREEZE project. As you all know, this is the department's project to replace the antiquated CAS and ATS systems for enforcement and licensing. And we're moving forward, and it's on target for completion. Debbie Balaam is willing to provide a presentation to the board regarding this. We're finalizing the working sessions with the vendors, and I just want to tell you the process that this went through is different than pretty much any other state agency has gone through. We were allowed to pre-qualify vendors. We actually had 2 vendors that pre-qualified. They have been in for the last 3 weeks meeting with our staff and our subject matter experts to go through each of the requirements for this IT system. The problem in the past has been that the vendors don't understand the requirements, and then they submit a bid not understanding what is going to be required of them. So this time all the requirements have been gone through with the subject matter experts. We want to thank all of the boards that have provided individuals to sit with us on that. The best thing about it is that this is going to be a business-driven project, not an IT project, and we just hope that it meets the needs of all the boards. But in doing that, we also found out that we needed 3 work groups to really get together to identify some needs for the requirements as well. We've identified a forms revision work group because we believe that we should be able to identify certain items on each of the forms that are standard across all of the boards, so that will cut down on the cost of the project. Also, we've identified a data conversion work group because individuals coming in, you don't necessarily need all the information pulled over from the old systems. How long do you want to retain information on a deceased physician, for example? We're looking at that. And then the last one is reports work group, because I'm sure almost everybody on this board has asked Ms. Whitney or Ms. Threadgill for information, and the answer has been, I'm sorry, we can't get that data to you because our system won't pull that information. So we want to meet with the boards to identify what reports would be good to put into the system. Right now, if we just took all the reports we currently have, there's a lot of them that the boards don't use. So we want to identify those that are relevant to the boards, those that will meet the needs of the boards. And obviously, they're going to have the data in there and the availability to pull reports based on what we're getting right now for the enforcement and the licensing statistics. So those 3 work groups. And it does add up to staff time because we do need the subject matter experts from the boards. Unfortunately, you know, for them right now, in the future it'll be a great advantage, but for right now we need the resources to pull from them to be able to put together the project. And then the last thing, I just wanted to thank the board for webcasting its meeting today, and then also thank them for moving forward with the information on the healthcare reform. I know that we've been trying to encourage boards to get information out to them on the impact, and to have Mr. Schultz here today was a big help in moving that forward. And fortunately, we're going to be able to take that information back and hopefully have other boards have him speak in front of them. So,
Ms. Kirchmeier, I want to thank you very much. You should know that at every meeting we've been trying to have someone of some notoriety come and speak about healthcare reform. But also what you did bring up in to try and go before Mr. Zeroni and ask you the question as when is this interface going to happen with the two systems? When will that be complete and up and running?
I missed that. I'm sorry. I had it in my notes and skipped over it. We are right now putting out. She beat you to the punch, right? We are finalizing the system requirements right now. They're going to be put into the final request for proposal, which will go out at the end of December. And if everything runs smoothly, we are going to have the vendor in July of 2011, working with the boards, and it will be rolled out in December of 2012. That's when the system will be finalized.
Does the state have a system by which they might want to suggest that if they could complete the system sooner, for every month that they completed it sooner, there would be a bonus paid?
Well, because of the way this procurement method happens, this vendor actually is not paid because it's a transaction fee model, which means that they will not get their money until the system is up and running. So we say December of 2012, but if the vendor were one to want payment prior to that, they would definitely be moving forward in a more expeditious manner to get paid.
Incentives are always good.
Incentives are always good.
Do I have any questions or comments from any of the members of the board? I want to thank you very much for your report. Let's move on to agenda item number 36, please, and that is the agenda items for the meeting in San Francisco, January 27th and 28th. 34. Oh, we're going to put number 34 on the agenda in January. Thank you, Ms. Whitney, to start with. Anything else specifically?
No. We'll think of it. I'll call you.
Disciplinary guideline regulations?
Mm-hmm.
Let's see, the left hand is talking to the right hand is talking to left hand, but I don't know what's going on. So it's taken care of. Anything else? Okay, then we'll leave staff to do this as well as to keep us updated on whatever else is necessary.
The 28th of January is my granddaughter's first birthday, so...
Is she coming to San Francisco?
Yeah, should get her up there.
I think
by webcam. We'll webcast.
She won't know. She won't know. We won't tell her. She should have a birthday on the weekend anyway. So any additional comments, suggestions from the members of the board? Any public comments and suggestions? Oh, thank you. I need that in Ms. Thompson's hands.
My name is Michelle Montserrat Ramos, Consumers Union, California Safe Patient Campaign. In regards to the comment from the lady from DCA regarding requiring licensees to notify the Board of Arrests, it's really important. I mean, it really needs to be looked into. I've had that experience. Lloyd Montserrat lost his life because his physician had been arrested 3 times, 1 time for felony possession of crack cocaine. This physician should have been monitored. This physician is still practicing now. He's still harming patients now. I can't tell you how critical this is for this to be included, for licensees to be required to be notified of arrests. Thank you.
Thank you. Moving on to agenda item number 37, I will entertain a motion to adjourn.
So move.
Second. All those in favor? Thank you very much, members.
And thank you, Jerry, for a wonderful facility.
Well, I also I want to thank Diana Hundell, who's the CEO of Memorial Medical Center, because she helped arrange this and was, they said whatever they could do. So, and the Hyatt for being very cooperative about government rates.
I want to thank you for all your arrangement.